Okay, oh, the drama. Kaylee, my house is fine, but so many houses have trees fall on them, and a beloved venue got hit with a sold deck. I heard about that. And I know a lot of people that were hurt and the guy that died. Oh my God, we were on Good Morning America. Life, right? Life is just surreal right now. It's absolutely surreal with all the stuff that's going on. All right, so now I can start this formally now that I've got my Facebook stream running and my YouTube stream running. And again, things just went a little long with setting up the house and everything for my elderly parents. So my name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I am the longest serving IT support group leader in the United States at 30 years, and actually in the world now, I think at this point in time, because the Germans have retired. I bring to you several college degrees. I've got degrees in chemistry, pharmacology, drug development. Yes, I was a geek nerd. If I could go back to college right now and get a doctorate, I would. In microbiology, I would. I have a master's degree in psychology. And I, like so many of you, struggled with a history of pelvic pain. And you know, it's so funny that, and I kind of did this last night. I was, let's see, how do I want to say this? I was watching the new emergency documentary on Netflix, and I love documentaries. Doesn't matter what they are. I love documentaries. I'm so much my parents now. And they have a new documentary on the emergency room and emergency room staff and paramedics in New York City. And I really recommend it. I absolutely recommend this because it's, number one, it's real. It's not drama. It's not fiction. And it shows that the doctors are not the enemy. They're not. They're working their tushes off trying to help people. Paramedics, medical care in general are not the enemy. And that we all have our own stories. And it really made me think about my own journey with trying to understand my story. Because I think we all do the why me's, right? And I've done a lot of why me's over the years because I did not have a normal life. I had a lot of trauma when I was younger. Not my fault. I lived in a neighborhood with a kid my age who became a rapist murderer. I did not leave my home without fear from 4th grade through high school. I was an early victim, and I was a victim. And I was talking a while ago with one of my doctor friends who was at Harvard, teaching at Harvard, and she said to me, she said, Jill, why didn't you go to medical school? Because I could have. And there were 2 reasons why. Number one, I did a surgical internship for a year. I have this really rare pharmacology degree, drug science, drug research, not pharmacy, pharmacology, how to make new drugs. And part of that was doing surgery for a year. So I practiced at being an anesthesiologist. I practiced at being a surgeon. I'll tell you, making the initial incision is creepy. It's like cutting an orange. Ugh. And I think it's very important that we go where our natural talents are. And I did not have a natural talent for creating anesthesia and creating formulations. I didn't. And I think that if you're working with people and you're giving them drugs, you need to absolutely have an innate, intuitive understanding of that type of math. Even though I had calculus, I did a lot of math, it just didn't come to me. It's kind of like genetics. I barely got my pharmacology degree because I got a D in genetics. I just, bam, right over my head. And it wasn't until after I graduated And I brought my textbooks home the next summer, like literally 2 months later. I have my genetics book open and I'm like just reading it going, oh my God, that's what they meant. Like the light bulb finally turned on 2 months after I graduated. So anyway, so my scientific reason for not going to medical school was that I didn't think I grasped the math well enough. And this doctor from Harvard said, Jill, are you kidding me? We would have fixed that. We would have helped you with that. Why didn't you ask for help? This comes into my second reason, and that is fear, anxiety and fear. That the legacy of growing up with trauma, oh, thank you, Angie. The legacy of growing up with trauma is it creates a foundation of fear and anxiety. And even though I've had a lot of fantastic opportunities in my life, I was a presidential fellow under Bush. I interviewed at NASA. NASA offered me a job. I let fear stop me from doing a lot of stuff. I did. And I've always wanted to try to understand why. Because in my 20s, I was living with massive anxiety disorder, right? But I didn't understand why. And it doesn't help when there's a society out there that is critical of you when you're, it's like, Jill, come on, get over it. But you can't get over how you're wired and you can't get over trauma. And so I was watching this emergency room documentary last night and listening to the patient stories of trauma and the doctor's stories of trauma opened up this big thought bubble in my brain. But because in the end, and as I was saying to my dad today, I said, things come full circle. And I do believe that we all have a purpose. I do believe that we are here for a reason. I do believe that the things that happen to us when we're younger make us stronger. I do believe that when you've been traumatized, you need care for that trauma. And what was cool about it, there were two moments in the documentary last night that were really important. One of them was the ambulance team had gone to transfer a young child who had passed away. Unfortunately, the damage, if it gets hit by a car, was just too profound and they could not save this child. And as they came back and the ambulance got back to the hospital, and one other doctor asked this doctor, are you okay? And he said, he said something like, we just couldn't do it. We couldn't save this child. And then he was processing it. He was going, there is physical injury and then there is mental injury. And there's, New York City emergency lives. Exactly. But we also have to respect the emotional trauma, the mental trauma of being confronted with things that are very, very difficult that we have to process those. We have to talk about those. We have to get them out. And, I've worked with so many of you. And so many of you have such difficult stories. And yet, God dang it all, we are survivors. We are here. We made it. You are strong. You are productive. You are brave. You are caring. You are loving. You are worth it. You are worthwhile. You are an important person in your family. You are an important person in your country. The other thing that was really cool was they were doing surgery on a student, the partner of a med student or orthopedic resident who had a tumor, a benign tumor in her brain. I think that was the surgery. And so they were all gathered in everybody was ready. They were in the OR. She was anesthetized. They were gloved up. And the surgeon actually stopped everybody and said, let's do some mindfulness here. Let's do some mindfulness. The opera singer, yes, exactly, the opera singer. Okay. And so he had everybody to basically take a step back, and they did their very purposeful 3 deep breaths in with their eyes closed and out. In and out. And to see, so we talk about mindfulness in the IC world. We talk about grounding ourselves in the IC world. And a lot of us over the years have basically said, I don't want to hear about that crap. It's my bladder. Don't tell me to do mindfulness. Don't tell me to do a deep breath. And yet here we have one of the most brilliant neurosurgeons in the world who does this before surgery. So he is capable and present and grounded, you know? So anyway, my brain has just kind of been dancing around this concept of purpose and this concept of that we all have our own stories, and we all have our own stories with pain, and we all have our own stories with IC, and we all have our stories of how we've been treated, and we all have our stories about what we would like to do in our lives versus what we did not do because fear stopped us. And as Amy said here, I'm realizing that a lot of my pain is correlated to childhood trauma. And although it's not bad trauma or physical trauma, it's still trauma, and it still affects me mentally. Nobody's saying that trauma causes pain. You know, listen, the fact that I was assaulted as a child by a rapist and murdered, that didn't cause my bladder pain. That didn't cause, it didn't. But it left me living in anxiety for the vast majority of my life. And what's amazing is I have another dear friend who, I kid you not, is, if you could see him play tennis, he looked like Bjorn Borg. The most graceful, handsome, brilliant player I've ever seen in my life. And I've known him for many, many years. And he never really was like normal. He didn't really spend a lot of time with guys. He spent most of his time with women. And I didn't really quite understand that until he shared with me that he had been raped as a child by a stranger twice. Same guy, 2 times. And his mother did not believe in getting therapy for him. So he had no support. And as an adult man, he was scared of men because he was never allowed to process that trauma. So as we talk about our lives and as we talk about our pain struggles, there is a seat at the table for trauma without any shame, without any blame. I know as an adult, I did nothing wrong. I know as an adult, I was a child who was hurt badly. Lori says, exactly, this is me too. And a lot of people ask me, they say, Jill, why aren't you married? Why don't you have children? Now, I've come close a couple of times. I'm very close. The first man I fell in love with, unfortunately, ended up dying of MS. Anyway, there was another one, Earl, who had cancer. I tell you, it's kind of like this experiences kind of grounded me. This was in my 20s also. But in the end, I'm going to tell you exactly why I'm single. It's very hard for me to trust a male figure. And as I talk to so many of you, I realize I have a lot of sisters out there who also did not get married, who also did not have children because we were hurt. It shouldn't have happened. It shouldn't have happened. And over the years, I have these moments where it comes back and God damn it, I wish it had never happened to me. I was supposed to have 5 children. I was supposed to be a grandma. But this one mentally ill person changed that. But maybe they didn't. Maybe my purpose was actually, I mean, I kind of believe that with every lifetime we come with a purpose. And maybe my purpose for this lifetime was not to be the mom that I was in a past lifetime. Or maybe I'll get to be a mom in my next lifetime. Maybe my purpose for this lifetime is to be in service, kind of, sort of. So anyway, that's just kind of where my brain's been in a weird place since I watched that last night. Eliza says, I know exactly what you mean. Angie said, I was so angry for years after my psychology test showed my PTSD, anxiety, and depression. I was still in denial after cognitive therapy pulled it out of me. In my mind, I was fine. None of that was affecting me. I wasn't dwelling on any of it, but deep down in my mind, it was controlling me. It's difficult to come to terms with how things affect you. It was a hard journey, but I finally overcome it, the guilt and denial. Like Angie, like I'm like 90% there. But I think I'm going to start some trauma therapy this spring. I do. I feel like there's just like one more piece that has to come out. And that's the other thing about this documentary that I think is so interesting is they're actually talking about the trauma of COVID and how that changed everything. That so many people, because of COVID, did not get the medical care they needed. They couldn't get the meds they needed, and then the emotional trauma and all that sort of stuff. I mean, you got to have your head in the right place to watch it, but it's not a bad documentary. I think it's pretty good. And I just want, for those of you watching who have a history of trauma in your life, honey, I just close your eyes and just pretend that I'm right there. Oh my God, and I'm giving you the biggest hug in the world because you need it and you deserve it. And we love you and we care for you. And you are not alone in this. And the best part about it now is that we get to move forward much more informed. We get to move forward with better treatments and with better outcomes. So I would love to hear your stories. I'd love to hear more stories of patients. I would love to hear the things that you've overcome. I would love to hear the things that you're struggling with. I would love to hear something funny. Like, okay, I got to tell you the single funniest IC moment I've ever had in my entire life. And it was over in the old America Online IC support group, and it was with Patty. And I don't know where she is now. We had hysterical times back in the old IC groups that don't exist anymore. We, for example, we created a storyline that was Princess Pia-Lot and Sir, Princess Pia-Lot and Sir, there was a Sir. Anyway, we had hysterical stories. We were talking about how back then, how difficult it was to travel, right? When you got to pee all the time, especially before the era of Starbucks and a lot of fast food, you're back in the 60s, back in the 70s, when you're driving, you ended up pulling over at nasty old gas stations with foul bathrooms, like the worst of the worst of the worst, black floors, grimy urine, you know what I mean, nasty bathrooms, right? So anyway, she was hysterical. It was one of the funniest moments of our lives talking. And she said, so there were no bathrooms for 100 miles, but we found this nasty little old mom and pop gas station. And Jill, I was desperate. I didn't care. Get out of my way. Unlock the frickin' door. I need the toilet now. And she goes running into the bathroom. She didn't care. She barely looked, right? Slams the door, sits on the pot, even though you don't want to, and lets fly. It's like, oh, thank God. I've got a bathroom, right? Then she opened her eyes and looked around. Number one, she was in the men's bathroom instead of the women's bathroom. And number two, the door was broken and she was locked into the stall. So now she's done. The family's in the car. They're trying to, she's trying to find a way out. And she actually like looks at her surroundings and she realizes nobody has washed this floor in 5 years. And the only way to get out of the bathroom was to lie on her back on the floor and go underneath the door. She was just so funny telling this story. It was absolutely hysterical. And yes, that is what I don't remember what she did, but she had us rolling laughing. So we have to find the funny moments in this too, right? There are always funny moments in life. Eliza says, unfortunately, in Romania, they don't believe in this kind of therapy. Well, this is where there are a lot of really good books now you can get, and you can kind of work through it yourself. But it's always nice to have somebody that you can talk with. There's also people online that you can talk with too. Dana said, whether it was intentional or not, as a child, my dad's death, I believe, had a similar effect. Yeah. Trauma's real, hon. Physical, mental, emotional. It affects everything. And Eliza said, I got a female urinal from Amazon. I pulled over and started to use it. This guy stopped to ask me if I needed help. So I threw my white coat on my lap and tried to act normal, telling this guy I'm okay. Oh, I have a, here, hold on. I have an interesting, let me see if I can find it. Hold on. Okay. So if you're ever in that situation, where you need to go and you finally found a bathroom, but you know, they could pay you $1,000. You're not going to touch that toilet, right? What are you going to do? So there are these devices here that are actually female urinals like this, so that a woman can pee standing up. Because honestly, I envy guys who can just unzip and pee. They don't have to drop trowel. We have to drop trowel. Not if you use something like this. And it's a female urinal. And so basically this will just slide right, you know, over your urethra. So you can be standing in a nasty bathroom and never have to touch anything. You just slide this over your urethra and a female will pee like a guy. And these are actually quite popular. I don't remember the name of this one. I tried it and it didn't even leak. It did not even leak. I was really impressed. So having something like this, also, I will tell you, in my car, I have travel johns in my little storage area. So that if I ever feel like I'm in a situation where I need to use the restroom, I'm just going to whip out a travel john. It's always good to carry a big towel. Carry a big towel in your trunk. Hi, Talat. And a plastic bag. Get a garbage bag. Fill it with a couple of towels. If worse comes to worse, you can just sit on top of a towel and pee, and then tie it up and wash it when you get home. Got to have plans. I once got stuck on the Golden Gate Bridge without a bathroom. And I did not stop in Marin County to use the restroom because I thought it was through. And I was stuck on the Golden Gate Bridge. I was driving down to a doctor's appointment. And we were stuck there for 20 minutes. And my bladder was screaming at me. And it's a miracle I did not leak. I don't know how my bladder held it. I think if I tried to do that today, my bladder would just say, hey, Jill, yeah, tough. I'm going to pee. Amy says, Dr. Eckenberg has helped me so much with explaining how pain works. He's literally the best doctor I've ever seen. He's a giant teddy bear. So sweet. He is. Dr. Eckenberg is literally probably the best pelvic pain doctor in the United States. He practices in Pennsylvania. And yeah, he was supposed to call me. We exchanged cell phones. He wanted to talk. We just haven't been able to connect. He is dedicating the latter part of his career not only to helping patients, but also in educating care providers to look beyond that. Now, the other big thing that happened, just so you know, is we had our first committee meeting for the AUA guidelines on the development of pelvic pain, the AUA committee for the development of guidelines for male pelvic pain patients. And it was just a fantastic meeting, 4 hours long, a couple days ago. And it's so much better than it was. These are going to be amazing guidelines. I'm not allowed to talk about what they say or speak as an expert or speak as a representative. It's a 2-year commitment on my part. But I'm really, really excited about what I'm seeing and the future of care for all of us. Because I kept talking trauma-informed care, physical trauma, etc. Shlomo says, good evening. Can you expand on the relationship between symptoms and source? Last week, you talked about the timing of her transition. Was it before or after her change? Was it according to the type of symptoms? Big thanks. Shlomi, I think what you're referring to is the concept of cause versus effect. So when you've got interstitial cystitis, you've got to understand that that name really doesn't mean anything. And everybody admits it. And they've admitted it for decades. The name interstitial cystitis means it was created back in the early 1900s when they thought this was a disease of the interstitial layer of the bladder wall, but it's not, and it never has been. And in Europe, they will no longer be using the term interstitial cystitis. They're going to be calling it primary bladder pain syndrome or urologic chronic pelvic pain syndrome. And that's going to happen in the US too, sooner rather than later. So you've got symptoms of frequency, urgency, pressure, pain. Why? Now, your immediate assumption is infection, but the cultures come back negative. There's no sign of infection. The symptoms are the effect. You are an anatomical mystery to be solved. We have got to now figure out why you are struggling with urinary symptoms. Why? Could you have infection? Sure. You absolutely could have infection. You could have a bacterial infection, you could have a fungal infection, or you could have a viral infection. And it was so interesting. I was working with a patient who had she had a genetic something. Anyway, she had this terrible viral infection, and it was a virus I'd never heard of, and they were really trying to treat it. It was challenging in her bladder. But once you could have an STI, and the vast majority of us have been tested for every sexually transmitted disease known to man, and they all come back negative. And then they look in our bladder and they go, oh, you got a pretty normal bladder. I'm not saying anything pretty alarming. And you're going, well, then what is it? Because I'm not here because I enjoy being here. I am up all night peeing. Why do I have these symptoms? What is the cause of these symptoms? The symptoms are the effect. What is the underlying cause? And that is your challenge now. That is all of our challenges now, is to try to focus on anatomy, underlying anatomy here. And that is why we do phenotyping, subtyping, because we don't want you to waste 20 years. I was working with a patient who'd been on a medication for 17 years. Whenever she stopped it, her symptoms came back. And I went, well, okay, so you're doing a good job of chasing the symptom, but you're not fixing the underlying anatomy. What's the problem in the first place causing these symptoms? And in her case, it was estrogen atrophy. So although I think there was also some previous trauma too. Okay, so anyway, we do phenotyping to try to identify that underlying cause. So I use a system that focuses on 5 core variants. We have a new system that focuses on 9, not quite using that one yet, but Hunner's lesions, considered the most challenging cases of IC are patients with Hunner's lesions. These are open wounds in the bladder. they have in the past been quite resistant to traditional bladder therapies. Why? Well, for some of you with Hunner's lesions, it's because it's a virus. It's a viral infection. Our next subtype, but it can also be neuroinflammation. It can be the result of really bad trauma that's really badly affected nerves, and those nerves are now massively inflamed and releasing toxins into the bladder wall, which causes the ulcers. Okay, IC subtype 2, bladder wall driven. These are chemocystitis patients, but bladders that have been injured with some sort of chemical exposure. These are estrogen atrophy patients, and these are potentially patients with chronic infection. IC subtype 3 is our biggest subtype. These are patients whose symptoms began after some sort of muscle trauma. Having a baby, being in a car accident, falling on your tailbone, lots of coccyx injuries, lots of tailbone injuries in this group. IC subtype 4, pudendal neuralgia. These are the patients who have significant injuries that have gone beyond the muscles to the nerves. So if you have pain when sitting that gets better when standing up, that is a pudendal neuralgia. So our therapeutic priority for these patients is to try to identify the nerve that has been traumatized, figure out where it's been traumatized, address the cause of the trauma, aka that tight levator muscle, and calm the nerves down at the same time. And then our last subtype are widespread pain. These are the patients who have IC, IBS, vulvodynia, fibromyalgia, TMJ, migraines, etc. You only have to have two of those, two of the related pain conditions, to be diagnosed with widespread pain. And our therapeutic priority for this group of patients is to calm the nervous system, because these are the trauma patients. These patients are struggling with massive levels of anxiety. And now we know why, because what the research shows is for 80% of the kids who eventually develop widespread pain syndrome, there is a history of physical trauma. And for the other 20%, there's a history of abuse or bullying. And so therapeutically for these patients, and I'm in this group, I started this meeting talking about my trauma. I'm absolutely in this group. I had frequency urgency in junior high. I had vulvodynia in high school. I had IBS in my early 20s. I got migraines in my mid 20s. I got bladder pain in my early 30s, et cetera, et cetera. And the challenge here is when you're the patient, you think you've got, I must have a bladder disease. I must have a vulva disease. I must have a bowel disease. I must have this. Oh my God, what else is going to happen to me? When in fact, the connection between all of those is the central nervous system. And we have research now that has helped us understand why patients are sometimes prone to having widespread pain, because it's a central nervous system injury. And Laura said, how do we calm our nervous system? With mind-body medicine. Mind-body medicine works. So Laura, let me ask you this question. So people who have widespread pain, we tend to have very sensitive skin, a wicked sense of smell. Sensitive is our middle name, basically. Anxiety disorder, lots of anxiety disorder. And what that research now shows us is that our brain is in a constant state of fight or flight, that there was a trauma early in life, or it can be later in life also, that has programmed the brain into thinking that your life is at stake 24 hours a day, 7 days a week. And that's not normal nervous system behavior. Normally, fight or flight only turns on in a moment of severe life-threatening stress. If you were to open up your front door and you see a tiger across the street, your sympathetic nervous system has taken charge, your brainstem. The language of the brainstem is sensory information. There's no thought behind this. It just has one job. It sees a threat, it takes over, it prepares you to run for your life or fight for your life. Now, you're smart. You see the tiger, you shut and lock the door, you call the authorities, they come out, they trank the tiger, they take it away. It's now an hour later, the threat is gone, life is good. You should not be in fight or flight anymore. And at that point in time, your calming nervous system, the parasympathetic nervous system, retakes control of the brain and it calms everything down. But that's not happening in those of us who have fight or flight. But we know, and that's just, again, that's the result of injury. It's not mental illness in any way, shape, or form. It's injury. So how do we turn that off? Is with good sensory information. We have to prove to your brain that you're safe, and we can do it. If you guys give me 3 minutes, we can turn off fight or flight. I promise you, we can turn it off. It's just, you have to understand the language of fight or flight, and that's good sensory information. But before we do that, let's just get through questions here. Hold on one second. Let me go over to YouTube here. Card C, do they ever include a high whole food plant-based diet in the guidelines for pelvic pain and reducing animal products, oil, sugar, and salt? Nobody's done that in depth, but we should. I'm going to agree with you that it's very, very important for us to clean up our diets, to clean up the sugar, to clean up everything, to reduce inflammation. Kayleen here said, I was told with me getting abused all my teenage years while my body and mind is growing, it's more damaging to my nervous system. I'm convinced that the endo and the IBS is genetic, but everything else is from abuse. Yeah. Yeah. But how do I want to say this? Your nervous system is not your soul. It's not your spirit. Your nervous system is just how your body works, right? And this is where, Kayleen, we have to change the narrative in our brains. Because you are a beautiful young woman with a beautiful future ahead of you. And I know that it takes time to process the trauma correctly so that you can go live the life you deserve. And to not give the abuser another minute, a moment in your brain, because they don't deserve it. Lori says, so people with severe anxiety take antidepressants that may help? Well, depression and anxiety are often linked, but anti-anxiety agents rather than antidepressants are often suggested. Like, the name will come to me. San Marcos says, you had a fulguration last Thursday. I just had the same surgery, October 22. I cannot live like this. Painful recovery. I was bleeding so bad and the pain was too much. I adhere to the IC diet, started pelvic therapy, started taking yoga to reduce stress, but I'm losing hope. I'm a healthy 57-year-old, but I'm losing hope. Okay, San Marco, number one, big giant hug. And this isn't just a regular hug. This is like, I'm shaking you like this. Oh my God, we're in this together, girl. We are in this together. You are not alone in your struggle, okay? You're doing so many good things. You've changed your diet. You're doing pelvic floor physical therapy. You're doing yoga. I applaud you for that. Girl, excellent job. Lesions are little devils. It's just like, where is this freaking lesion coming from? And so the question that I would be asking your doctor, I would be very proactive and very assertive with this. First thing I would ask is, are they the same lesions or are they new lesions? Did any of the lesions heal? So if I started out with 5, but now there's only 2 in there, and yes, you recauterized 2 or re-injected the 2, it's important that you get the details like that, because if you have fewer now than you did 5 months ago, that means something really good is happening. Okay. It's also very important that you come back and you read about lesion therapy. Okay. Because number one, we can laser it. We can inject a steroid into it, but hyperbaric oxygen therapy. Hyperbaric oxygen therapy, there's no surgery involved. Basically, you're in a pressurized room with a lot of oxygen that gets pushed into your system that helps your body heal. So you got some really good research now with hyperbaric oxygen therapy, also called hot therapy, and Hunner's lesions. So that would be something that you could potentially try. And we had somebody come into the support group meeting here on YouTube a couple weeks ago who had just finished 3 months of hot therapy, and she was doing amazing. So that would be something that I would be very interested in pursuing. And then the other thing, San Marco, that I would want to know, I've told this story. We had this case study of a woman with severe Hunner's lesions who also had a severe prolapse. And when they went in to repair the prolapse, they made a remarkable discovery that her uterus was backwards. The front of her uterus was facing backside, and the back of her uterus was facing front side, because one of the ligaments had broken. So her uterus was free swinging like this, okay? And as it was doing that, you ended up with what we call a strangulation injury, right? It was twisting, which is never good because that messes up nerves and blood vessels. So anyway, they make this discovery that her uterus is in the wrong spot. They reattach it. And what do you think happened? Her Hunner's lesions healed completely. She is considered a complete and total cure. And I can find you that case study. So the name of that condition is called posterior fornix syndrome. And okay. Think about okay, I'm trying to find a good example. Think about no, that's not a good example. I have to draw it. Hold on, let me get a piece of paper. Let me draw it. Okay, that's backwards. Hold on. Okay, hold on. I got to draw this because I want you to understand. I want you to understand what happens here. Okay. That's backwards. My brain wants to draw it backwards, and I don't want to draw it backwards. Okay, so hold on. Okay, so here's the cervix. Here's the vagina. Okay. Okay, I got it. So hold on. Okay. When I retire, I want to go into art. I want to paint and quilt and stuff. I'm obviously showing I don't have much talent for this. I need 2 colors. Hold on, you guys. Just give me a moment. Okay, now it's working. Now my drawing is working. Okay. Okay. I want you to look at this picture for a moment. You would think that when the uterus meets the vagina meets the cervix meets the uterus, it's just like flat, right? Like you would think it would be like a pipe. Here's the vagina, here's the uterus, bam. It's like a pipe connector in the middle, right? The cervix is kind of like a pipe connector in the middle. But it's not like that. This is what it's like. So here's the vagina. and the vagina is going up here to the cervix, but there's actually pockets that push beyond the cervix. They're called a fornix, and they happen to be proximal to where the ligaments are that hold the uterus up. So what they will do, a way to see if you have posterior fornix syndrome, to see if you have a ligament that's detached, is they stick a wooden speculum right here, and they can, and if they, here, let me do it this way. They stick a wooden speculum right here, and if they lift that up, because you would assume that the vagina is now sagging on this side, this will lift it up and it will make the symptoms go away. Kind of, sort of. Anyway, oh my God, I'm sorry, I went off on a divergency there. Getting back to Hunner's lesion. So we have a lady who had severe posterior fornix syndrome. Her uterus was detached. They fixed it. Her lesions went away. Why? Because that supports our other theory of Hunner's lesions, that it's neuroinflammation, that clearly the strangulation injury affected the nerves. And once they got everything unstrangulated and got the blood flowing and got everything in the right position, the nerves calmed down and the lesions went away. Oh my goodness gracious, sakes alive. Okay, hold on. You guys are keeping me busy here. So San Marco, if you email me, icnetwork@mac.com, I will send you a link to that article so that you can read that, because I want you to get checked for posterior fornix syndrome. It'll take literally 30 seconds. Maybe that's why your lesions are recurring. It's possible. Cardstay said, I would think that maximizing the health of blood vessels and blood supply via plant-based eating with high leafy greens would help all parts of the. I agree. We need to go back to nature, gardening, walking in the woods for friends, etc. I completely agree. I already did it today. I went on a long, rambling walk this morning. Missy says, I'm wondering if vulvodynia is due to pelvic floor muscle and I feel pressure in my tailbone area. I'm wondering if I need pelvic floor physical therapy. Missy, you absolutely need to have a pelvic floor assessment. You know, when I think back about, you know, all the wasted treatments I did, only to discover after the fact that no, it was never yeast, it was tight muscles. Tight muscles that occurred because I had a broken tailbone, and tight muscles that occurred because I was in a constant state of fight or flight. My muscles were locking down. So pelvic floor physical therapy can absolutely improve, if not heal completely, vulvodynia. Also, no, Missy, when my vulvodynia was really active, the hot point for me was my perineum. Oh my God, my perineum was so painful. That's a piece of skin between the vagina and the rectum. And it felt like somebody had scratched off the skin with sandpaper. I mean, it was really rough. And I never really understood why, because I would go to, you know, the gynecologist. He'd say, Jill, there's nothing here. You look fine. You have the most sensitive skin I've ever seen in my entire life. It's like, okay. What he didn't explain to me is that immediately above the perineum is something called the perineal body, which is an attachment point for 4 muscles. And so perineal pain is usually caused by tight pelvic floor muscles. And let me show you a picture. Okay, so this is from the bottom. So up here we've got the urethra, then we have the vagina, then we have the rectum. And I want you to look, do you see that little round thing right there? That's what it says, perineal body, right there. That is a common place where people have issues. Card says we have a video problem on YouTube. I keep freezing. Well, you're on a completely separate internet. You're on AT&T. Facebook is on Comcast. So you should be, and you are on. You're hardwired in. You're not even on wireless. So I know it's good on my end, hon. So it's got to be an issue on your end. Okay. So anyway, Missy, go have a pelvic floor assessment. Let's find out. Rather than guessing, just go get the facts. We want to get an expert to check your pelvic floor and see if it's healthy. The fact that you feel pressure in your tailbone area is huge. So many of you have tailbone injuries. It's amazing how many of you have a history of tailbone injuries. Sandra says you had a fulguration on the 24th and now you're bleeding. Sandra, that's very concerning. You should not be bleeding. Did it just start or have you been bleeding this whole time? If you've been, Sandra, if you're still here, did it just start bleeding or have you been bleeding ever since you left the hospital for the fulguration? If it just started bleeding and you're peeing bright red blood, you need to call your doctor today. You need to call urgent care, the on-call doctor today. Something's wrong. Sometimes one of the most common complications of having, well, there are two common isn't the right word, complications that can occur after having a fulguration. Number one, just infection. Anytime you insert equipment up through the urethra, you run the risk of introducing bacteria up into the bladder. So you could have a post-op infection. That would be one thing I would consider. So Sandra said the bleeding just started. Sandra, are you peeing bright red blood or is your urine just pink? So bright red blood or is it just pink, hon? Is your toilet like filled with bright red blood? She said it just started and it's bright red. Sandra, if it were me, I would log off the computer and I would go to urgent care. Girl, get yourself off of this computer right now. You need to go to urgent care right now. You need to go right now, honey. She said her toilet is full of blood. You need to go to the emergency room. That's what I would suggest that you do, or at least call them right now and tell them what's going on because something happened. That's very, very concerning, hon. I do not believe you should sit on this at all. I think it's very important that you call your doctor now. Like literally turn away from the computer, pick up the phone, call your doctor right now and tell them that you're peeing bright red blood. Okay, honey? Big giant hug. In all likelihood, it's just a post-op infection. But see, the thing is that, honey, you could become anemic very quickly. This is a big hug. I'm giving you a big giant hug, okay? You can do this. You got through the hydrodissension. You got through the fulguration. You're going to get through this too. But right now, you need some help. You need some help. You need to have a doctor try to figure out what's going on. Sometimes what happens when they distend the bladder is because they stretch the bladder, it can weaken the bladder wall. And sometimes the bladder wall can kind of rupture. And so anytime they send you home with a catheter and you're peeing blood, that means that something happened to your bladder. That means that you were injured. So honey, if you're still here, I hope you've turned away from the computer and you just called somebody. But if you're here, please call somebody today. Okay? And just tell them you're peeing bright red blood. Everybody, can we just take a moment here? I just want you to take a moment. I want you to close your eyes and I want you to just send Sandra strength and love and support. Sandra, you've got this, girl. You've got this. You've got this. You can do this. But there are moments when we just have to ask for help. So let's make sure everything's okay. Okay? All right. Hold on a sec. Okay, we're coming back to Facebook here for a moment. Do hunters ever go away? Yes. Hunters have been known to spontaneously disappear, which supports the theory that it could be a viral infection that has just gone back into remission. What if the trauma happened 20 years ago? Trauma is trauma. It doesn't matter if it was 20 years ago or in my case 50 years ago. It leaves it leaves your body there are consequences to trauma, physically, mentally, and emotionally. And physically, your nerves change with trauma. Hello, Nick. Eliza said, "Oh no, sugar between celiac, IBS, Hunter's diet, sugar is all I have left." I know. I know. You know, if you're looking for really good resources for IBS, the IBS diet, the website helpforibs.com is fantastic. The Hunter's diet is just basically the low acid IC diet. And celiac is, of course, avoiding foods with gluten. I made gluten-free pancakes or waffles this morning, actually. That sense of sweet is wonderful. This is how I would challenge you. Rather than chemical sweet, go for natural sweet. So if you're looking for something sweet, do a sweet, ripe Fuji apple or ripe berries or a ripe banana or Manuka honey. Try to up your game kind of in that respect. We want to stay away from you guys, I do. Hey man, true confessions here. I might have one soda in every 5 years. One soda every 5 years. I could count on one hand the number of sodas I've had in 20 years. I probably had 3 or 4. Friday night, I wanted to celebrate, and I had a root beer. Low acid, caffeine free. Hated how I felt. I hated how I felt afterwards. Oh, just way too much sweet for me. I'm not going to do that again. I just do not like soda. I just, no. I was nauseous. Laura says, I have fibromyalgia, chronic fatigue, slow transit, constipation, severe migraines, clinical depression, history of abuse and trauma, had loads of really good psychotherapy and still doing it. Thought that would help my nervous system. It will. It will, but ultimately in the end, we have to retrain. See, Laura, the thing is when you've been hurt and traumatized in that respect, that brain is stuck in fight or flight. It still literally thinks that your life is at stake, and that changes everything. That keeps your heart rate up, it keeps your blood pressure up, it keeps your muscles tight. The language of fight or flight is good sensory information, and so the way we turn off fight or flight is with good sensory information. What do you see? What do you hear? What do you smell? What are you tasting? What do you touch? Sensory information. And so I do the technique I Spy, which basically has you visualize what's your favorite thing to look at. What would make you smile in an instant if you could look at it? Would it be a kite flying in the air? Would it be out at the ocean watching the waves? Would it be watching children playing, a horse running? Pick something, anything that you would love to look at. Close your eyes and visualize it. So I'm gonna pick the beach on a beautiful sunny day. The pelicans flying over, seagulls flying over. Okay, then deep breath in, deep breath out. We'll do an abbreviated I Spy right now. Now I want you to pick something that you would love to listen to. What would you love to listen to? What would put an immediate smile on your face? Would it be the ocean? Would it be your favorite music? Me, Kenny Loggins, or BPS? I was listening to Microcosmos earlier today. Somebody singing. Close your eyes and visualize what would the thing that you would love to listen to the most. Your daughter's voice, a grandchild, your favorite music. Deep breath in, deep breath out. What could you smell that would put an immediate smile on your face? What's your favorite thing to smell? Coconut, the ocean, fresh, clean cotton sheets, baking cinnamon rolls? Close your eyes and visualize what is your favorite thing in the world to smell. Baking cinnamon rolls every single time. Deep breath in, deep breath out. What could you taste that would put an immediate smile on your face? What is your favorite thing to eat? And I don't care if it's IC friendly or not. What is your favorite thing to eat or drink? Close your eyes. Visualize it. For me, I'm sorry, I got this plate of a hot, steamy, wonderful cinnamon roll, gooey cinnamon roll. Not only does it smell great, but oh my God, it tastes fantastic. I love me some cinnamon rolls. Deep breath in, deep breath out. And last but not least, what could you touch that would put an immediate smile on your face? Would it be a pet? Would it be warm sand at the ocean? Fresh cotton sheets, your lover? What could you touch that would put an immediate smile on your face? Close your eyes and touch it. What are you touching? Warm sand running through my fingers. Deep breath in. Deep breath out. That's how we turn off fight or flight. That's one of the ways that we can turn off fight or flight, is we just tell the brain we're safe. We do that with good sensory information. Dana says, what about hot therapy for inflammation? I'm not sure. Caroline said, I've had IC for 12 years. In 2019, I had fibroids, had them removed along with my cervix and uterus. I now have the same pressure as I did then. Is it possible to have fibroids again? No, because you don't have a uterus anymore. But I bet you got some muscle issues going on, Caroline. Usually that pressure can come from muscles, or it can come from blood vessels. If you feel like you're carrying a bowling ball around in your pelvis by the end of the day, that tells us that you might have the equivalent of varicose veins in your pelvis that are where blood is pooling as the day goes on, until by the end of the day it's so heavy you can barely walk. You go to bed, the blood all drains out. You wake up the next morning, you stand up, slowly but surely that blood starts to accumulate again. So I would be looking at muscles, I would be looking at nerves, and I would be looking at blood vessels. Donna says, is it okay to take Allopath and bladder rest at the same time? Sure. Of course, we're all different, so you have to try it yourself and see how you respond to that. Some people tolerate Allo and some people don't. I'm not a more is better person. I don't like taking more of anything. I think it's very important not to start adding more and more and more and more. I mean, number one, you make the supplement companies quite happy, but that's not our goal here. Our goal is to find the thing that will work the best for you. And the way we do that is with phenotyping and subtyping. And so bladder rest or Cystomend or Bladder Builder or Cystoprotect are really ideal for somebody with estrogen atrophy or a damaged bladder wall. Using that chondroitin to coat the bladder can be quite helpful. And then the aloe can be helpful just in kind of soothing the area. Just as aloe is soothing to sunburns, aloe can be soothing to the bladder wall also. But if I had to pick between one or the other, I would always pick chondroitin over aloe because chondroitin is found in the bladder and it is essential to the superficial integrity of the bladder wall, according to research that was presented in Europe a couple of years ago. The bladder is not made of aloe. The bladder is not made of plant material. So aloe is going to be soothing and might help calm some of the symptoms, but it's not necessarily going to repair anything or fix anything. There is a greater chance that a chondroitin-based installation or a chondroitin-based supplement might have more of a constructive effect. But we don't have a lot of research either. We've got some research, but it'd be nice to have more. Kayleen says endometriosis can return even after hysterectomy. Absolutely, but not fibroids, because fibroids are connected to the uterus. But you're absolutely right, Kayleen. Kayleen says, I love pineapples. Hold on. But my physical therapist said they're a bladder irritant. Yeah. Pineapples can absolutely be. In fact, I love hard ciders, although I've decided I'm not going to drink alcohol for an extended period of time. I just don't want to stress my body at all. But the single best hard cider I've had in my life was pineapple hard cider. And I will tell you, it was rough on the urinary tract. So I would agree with that. Renee says, what can you do for the blood vessels? An interventional radiologist treats them just like you treat a varicose vein on your skin. They're actually pretty easy to treat. Okay, I feel like I missed something here. Anne says, Fuji apples are delicious. They are. I just made Norwegian fruit soup with them yesterday. Just I sliced up 7 big Fuji apples, put them in, slices like this, put them in a big pot with some water, threw in some organic peaches and some prunes for my mom, boil it for 4 hours. Oh my God, it's so freaking good. It's so good with a cinnamon stick. That's it. Georgia said, is marshmallow tea good? Yeah, if you like marshmallow tea, go for it. But chamomile, marshmallow can bothers about half of the people who try it, whereas chamomile usually works for the vast majority of patients who try the chamomile. Renee says, out of all the IC supplements, what helps the burning the most? You have the PEA. I would say Allopath. I mean, again, so Renee, great question. And this is what we have to think about. The burning is an effect. We have to understand the underlying cause of the burning. So are you burning because you have estrogen atrophy and your bladder wall can't defend itself so much anymore? So urine is getting into your bladder wall or on top of your bladder wall, causing some of that burning? Or are you burning because you had soda? Or are you burning because your muscles are really tight? So actually, you kind of have to help us out here, Renee, and tell us a little bit more about your burning. Where is the burning? Is it on the outside on your skin, or is it on the inside? And if the pain is inside of your body, if the burning is inside of your body, where? Is it in your vagina? Is it in your rectum? Is it in your urethra? Or is it in your bladder? Tell us where the burning is. Eliza said, phenotyping, is that blood work? No, not at all. Phenotyping is based upon your symptoms and appropriate physical examinations. So to confirm if you're in the pelvic floor subtype, you need to have a pelvic floor assessment. To confirm if you have Hunner's lesions, you're going to need to look in your bladder. I mean, if you're peeing blood and you have severe diet sensitivity and severe pain and discomfort, that's when you want somebody to look inside your bladder and see what's going on. You know, like with Sandra, who was just on YouTube here, who was unfortunately peeing blood. That's when we want somebody to look inside the bladder and try to help us understand what's bleeding. Caroline says, what could I do? Pelvic floor consult? Can't hurt. You want to go to somebody who has who's certified in pelvic floor work. There's a website, pelvicrehab.com. That's really good. Pelvicrehab.com will help you find a physical therapist who specializes in pelvic floor work. You can just search by zip code. Kayleen said, when I jumped in here, I was picking up estradiol cream to hopefully calm down the, okay, it's got to be pressing up against my urethra. Hopefully, you know, it's very important to just get that skin as healthy as you can. And that estradiol cream would play a role in that with, you know, severe atrophy, which if I remember correctly, you have, right? Denise says, why when you have a full bowel constipated, why does your bladder hurt so much? Because they're right next to each other. They're right next to each other, hon. I mean, the thing you got to understand about the pelvis is, here, hold on. Whoops. You know, I can demonstrate it, but I wonder if I can find a better picture. Let me see if I can find a picture in this book. This is a good picture for patients to understand how muscles affect nerves. So here's your sacrum right here. And these are the nerves coming off of the sacrum, going through the pelvic floor muscles, through what we call the Alcock's canal. And so you can easily see how if these muscles are messed up, they're going to compromise those nerves. That's a good picture. All right, let me see if this book has a picture. Okay. So here's the thing about the pelvis. It is a small confined area with a lot of stuff going on. So enter the pelvis, correct? This is the front. Here's your pubic bone. Your pubic bone is actually two bones connecting in the front, connected here, right? We turn it around. Hello. Vertebrae, spinal cord vertebrae. This triangular bone is your sacrum. Here are the holes that the nerves go out into the pelvis. And of course, down here you have your tailbone. And I want you to look at this tailbone. Look at everything that connects to this tailbone. The tailbone is basically the center of the pelvic floor. And so if this tailbone is skewed one way or the other way, that can mess up these muscles right here. Now let's look at the inside for a moment. So here's the inside, right? These are skeletal muscles. These are the muscles that help you open and close your legs, help you move your body. Now we got to put stuff in. Western medicine fails the typical pelvic patients because doctors play in their sandbox. Urologists stay in the urinary tract, gynecologists stay in the reproductive tract, gastroenterologists stay in the gut. They don't look at relationships. And what this is all coming down to is relationships. Nothing operates in isolation. Everything influences everything. So this is a female one. So let's go ahead and put in. Okay, hold on. I got to put the lower levels of muscles down. Okay, so the first thing is we're going to put in the vagina and the uterus. Done. Then we're going to put in the bowel, which is going to squeeze over here, right in there, left side. Am I connecting it? Okay, well, basically, here, hold on, that's not connected. Ah! There's the hole. I got to get the bowel and the rectum. Maybe it would be easier if I put the bowel in first. Okay, so here we go. Yeah, there we go. Now I got the bowel. I now see I've got the lower intestine connecting to the rectum on the bottom. Now I'm going to stick the uterus in, the vagina and the uterus. Ugh. Things want to move. Okay, so now you can see the bowel sticking right up here. And now we're going to put in the bladder. And the bladder is basically going to go right there. So you see how close they are? It's very common for patients with constipation to struggle with, I see patients who get constipated to struggle with an IC flare. The question is, what kind of flare is it? It's not a bladder wall flare. It's a proximity pelvic floor flare. Does that make sense? Kind of, sort of? Also, just know that a lot of that rectal pain that you might think is hemorrhoids can actually be a spasm of the levator ani muscle, which is the muscles that wrap around. See, here's your rectum. Hello, muscles right there. So if these muscles are super, super tight, bam, you're going to have rectal pain. Renee says, I use estrogen 2 times a week. Muscles, no. Okay, the burning is inside. You have vulvodynia, back in pelvic therapy. Just wondering what supplement might help too. Well, I think that the PEA is going to be the thing that's going to calm the nerves down the most. But if you've got some estrogen atrophy and your bladder wall is not as strong as it used to be, I would be doing something with chondroitin in it too. Melina says, what can I do around that time of the month? And urgency increases. Seems like I only flare around my cycle. I have a tight pelvic floor. So you need to be in pelvic floor physical therapy. As estrogen levels go up and down, it influences muscle health and bladder health. And that's how you're going to know when things are going to start, when you're starting to get better. When the symptoms start to ease and you no longer have that ovulation flare or that flare before your period, that tells us that we're on the right track. I was that way for a couple of years, and finally it just went away because my muscles finally got better. You could be a little proactive here. I mean, maybe a day or two before you ovulate or before your period starts, maybe you could start some allopath for a couple of days. Allopath is a combination of aloe and PEA. That's the aloe that we suggest now. So it's going to be soothing to the skin, but it's also going to potentially calm nerves down. So allopath would be interesting to try. Maybe. There's a lot of stuff out there, but I just think it's very important to be grounded in anatomy and thinking about what are you trying to accomplish. I hope that makes sense. I feel like I missed something important here. Denise says, very interesting. Thank you. Renee says, thanks. Dana says, so Cystomed is better for the bladder wall? Definitely. Cystomed is probably the strongest supplement out there to help bladder wall health because it has the most chondroitin in it. So yeah, I would definitely put Cystomed at the top of that list. But if you also struggle with pain, then Bladder Builder is a more dynamic supplement because it also has PEA in it to calm nerves down for pain relief. So if you just had frequency urgency from estrogen atrophy, Cystomed. But if you're also struggling with a lot of symptoms and a lot of pain and discomfort, I would Bladder Builder, I think, makes a little bit more sense. Well, you guys had me jumping and now you're all quiet. Oh, so you guys, I need your help. We have a dilemma. Here's the dilemma. IC Awareness Month is in September. Pelvic Pain Month is in May. And we have facilitated IC Awareness Month for the last 10 years or so. And it's very hard for me to do. It's been very hard for me to do because September is fire season out here. And we've had our worst fires. These are firestorms, guys. Like you're up all night, you're watching your evacuation routes. I've evacuated 3 of the last 5 years. We almost lost our house 2 years ago. I mean, the fire was 3 houses away from our house when we drove away. We all thought our house would be gone. It was saved by a bulldozer. And I live in a neighborhood, you know? So there's a part of me that really wants to move IC Awareness Month into Pelvic Pain Awareness Month. Because again, they're not going to recognize IC as a disease in Europe much longer. This is a pelvic pain condition. So what do you think? What do you think about that? I mean, I like the idea of having a separate month for IC, but in the end, the term IC 20 years from now will be non-existent. Chloe says, what am I drinking? We've been drinking just water for the past few months as I am following the IC diet to a T. Water is so boring. So you have to remember that I am not a bladder wall patient. My bladder wall is healthy because all the early damage that was done has healed, and I use estrogen to keep my skin strong. So my bladder can tolerate stuff now that it would never have tolerated 20 years ago. So I am drinking tart, very, very dilute tart cherry juice for as a little umph for stress management and my blood pressure. And it doesn't bother me at all. But again, I wouldn't do that if I had Hunner's lesions, that's for sure. Linda says, thank you, Jill, for being such a wonderful resource for me during a very difficult time in my life. I hope you realize the impact you're making in so many lives. My IC diagnosis was back in 2007. Girl, you're an old timer, aren't you? It's my honor to be here and to be helpful. I really want to be as helpful as I can be because I know what it's like to be, suffering and alone. It's hard. So I'm really glad that I was able to help. How are you doing now, Linda? How's your symptoms? You feeling better? All right. So Dana, Dana said she missed it. So IC Awareness Month is in September. Pelvic Pain Awareness Month is in May. And I am pondering moving IC Awareness Month and merging it with Pelvic Pain Month because IC is not going to be used as a disease name much longer. It'll be gone in 20 years, maybe 10. This is considered a urologic chronic pelvic pain syndrome or a bladder primary pelvic pain syndrome. And it makes a lot more sense. Linda said, my IC was helped by PT and diet. Now I find myself with TMJ. Linda, me too. Me too. And I just think that my pelvic floor is fairly good. My my bladder is perfectly fine now. My vulvodynia is gone for the most part. IBS is gone now. But the TMJ kicked in big time during COVID. Big time. By the way, my best friend from high school has COVID now because her freaking employer, a health company, thought, hey, COVID's over. Let's come have a big meeting. 80 people in a room all day. Yeah, guess what? COVID outbreak. And it's not easy COVID. She's having a rough time. She was having a rough time. So what are you doing for your TMJ? So my TMJ kicked in about 6 months into COVID. And I haven't slept in my bed in almost 3 years. I'm sleeping in a recliner. And every morning I have to push on this side to pop the joint back up into place. If I lay on my back, so the ligament on this side has stretched out. And I have arthritis on this side. The only arthritis in my whole body is in my right jaw. So this side is tight. And what they're saying is this side is so tight that it's forcing this side open more, like squeezing, and so it's forcing it open. So here's your jaw, tight. So it's not like it goes like this, it goes like this. So if this side gets tighter, this side gets wider. So I'm dealing with my jaw just basically wanting to dislocate. I was diagnosed in March of 22. Physical therapy's helped a bit, but I'm still having, I know, me too. I was in physical therapy for 2 years. And the physical therapist was just saying, Jill, the problem really isn't your jaw. It's that you're tight from your shoulder to your ear. You're just tight on this side. And that's from an old car accident where I got whiplash, and it's also from my scoliosis. So I'm tight up here on the right side, and then I'm tight down here on my left side because I have an S curve. And so I'm going to a TMJ specialist in August. We have a 1-year waiting list to get to the physical therapist. So my appointment is in August. Cross fingers and hope there's no fire that day, and hope that I can get somebody to come stay with my parents that day, because I want to sleep in my bed. My bedroom was my safe place. My bedroom was where I could just close my eyes and rest. I literally haven't slept I slept in my bed once in 3 years. I sleep on a freaking recliner next to a dusty bookcase in my family room. And I had a chance to go to a physical therapist. I mean, when it first kicked in, like when I could feel it getting bad, and my dentist at that time said, hey, we should send you to a TMJ specialist. I went, oh, no, it'll get better. Oh, what a lost opportunity. I could have seen somebody 3 years ago. I really regret that because it's just gotten worse. Linda said, I'm tight on my left side temple down through my neck and arm. I hope the specialist help. Yeah. Isn't it interesting? You know, some of the TMJ work focuses on fascia. That literally you could have TMJ from a fascia injury in your feet. because your fascia is basically one solid piece throughout your whole body. It's all connected. And if we've got dysfunction on the lower right-hand side, that can affect something, on the upper left-hand side. So, Linda, if you can, get to a TMJ specialist. The other thing for me is that the mouth guards always made it worse. Always made it worse. I first dislocated my jaw like 20 years ago. And I dislocated it at night, literally at night. Apparently, I sleep with my mouth open. And I rolled and it dislocated. And I woke up with my jaw dislocated like 20, 25 years ago. So there's some forms of TMJ that get much worse with appliances. Linda said, I'm headed in that direction myself, but healthcare in New Hampshire is an issue. It takes forever to get employed. Yeah, they just told me flat out it's a 1-year waiting list. So I've been on the waiting list now for 5 months, and my appointment would be in August, and that was earlier. And I still have to drive 90 minutes to get there. And guys, I haven't driven anywhere during COVID. Like literally, I've stayed home, caring for the folks. I haven't driven down to San Francisco in 5 freaking years. It's been a long time. Like I said to my sister, I said, oh, let's hope I can get there. I think I'm going to have to go practice and take a couple of drives first because it's been a while. Linda says, all the best. You rock the show. Thank you, Linda. Thank you. Hey, good luck. And if you find any good tips on the TMJ, please let me know. Please let me know. I would really. And also the TMJ Association is fabulous. They're a fabulous nonprofit. So if you can, go support the TMJ Association too. They're leading all the chronic pain research. Peace to you, honey. Big hug. Eliza says, on top of Hunner's, I have estrogen deficiency due to hysterectomy at 38. Was told to use estradiol, but when I apply it, I get pain. Not sure where. It just feels like the vaginal and pelvic pain. Any idea why that? Okay, that's very common, honey. Eliza, that's very, very common. You have to remember that you're not just in estrogen atrophy, you're now in severe estrogen atrophy. And so think about your skin. Your skin is dry. So what does that mean? Well, it means that, here, look at it this way. So here is a view of the bladder wall, okay? But this also kind of applies to the vagina too. So the bladder has a thick coating of mucus on the inside. And look at what it does. It acts as a barrier. It prevents the irritants from urine from reaching the urothelial cells. These are the critical cells. These are the largest cells in the human body. They're fascinating cells. And of course, underneath this layer of skin, we have blood vessels. So there's a blood vessel. See, here's blood vessel. And the green ones are nerves. And of course, they're not all that color. That's just for illustration purposes. So the problem now, hun, is that your skin is dry. So now whatever you put on your skin is going to reach, it's going to get through where the gag layer used to be, down onto the skin and down towards the nerves. So it's a very, 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 very common for women who start using estrogen cream to report that it burns. It's going to feel hot. It is not burning you. It just means that your skin is dry. And every subsequent time you use that estrogen, your body absorbs that estrogen and it slowly starts to produce that mucus again. So what you should notice is the burning gets better every single time. Takes about 2 weeks to get to the point where it feels like a warm puff of air. At least that's what it took. About 2 weeks for me. The first couple of times I used my estrogen cream, it burned. It burned. But it gets better. If I don't use my estrogen cream for 2 weeks and I put it back on, it's going to burn again because I've let my skin get dry again. You have to, Eliza, you have to try to ride out the first 2 weeks. And I'm sure your gynecologist told you that. You just have to give it a little bit of time. It takes time for that skin to absorb all that estrogen, and you can watch under an electron microscope these cells get thicker and stronger and start to produce mucus. But if you only try it once or twice and you walk away because it's burning, you're completely missing the point. John says upper body physical therapy and fascia. Exactly. See, that's the thing with COVID. I used to get a lot of massages on my neck. I mean, I had massages all the time because you try sitting at a computer for 8 hour night. Well, not try. So many of you do it, but as you get older, it gets harder. And so I was doing a ton of neck massages, but I haven't had a neck massage in 3 years, and that's the TMJ, really bad. John says it, and upper body and fascia release help my TMJ. Yeah, you're inspiring me. I was just very reluctant to do it because I didn't want to expose my parents to COVID. But I have somebody that I can go to. I think I need to start doing it. Eliza, what I said about the estradiol is your skin, if you have estrogen atrophy, your skin is dry. Thus, the challenge here is that it doesn't matter what the chemical is. When you put a chemical on that dry skin, it's going to burn. Whether it is soap, laundry detergent, fabric softener, anything like that, without that nice thick mucosal barrier, the skin can't protect it as well. So the hard reality is that you're putting a chemical on your skin and it's going to burn, even if it's estrogen. But what you're not seeing is microscopically is those cells are immediately pulling that estrogen in. They're getting thicker, stronger, plumper, and they're starting to produce that mucus. So it takes about 2 weeks to go from the ow, it's burning to the it's not so bad. Eliza said it's deep pain. Eliza, where are you putting the estrogen in your vagina, or are you putting the estrogen on the skin on the outside? Okay, so you're putting estrogen cream on the outside and it's giving you deep internal pain? And obviously they've done a vaginal exam. They didn't see anything up high. Do you still have your cervix, or was it removed with the hydrodistension? I'm sorry, with the hysterectomy. What is that? Well, okay, a couple of thoughts come to mind. Thought number one is, and okay, the cuff is left. Okay. Could you have some remaining endometriosis by the vaginal cuff that when estrogen gets put on it, makes the endometriosis grow a little bit? Maybe. I'm guessing here. I'm not the expert. I'm just guessing here. What else could that be? Here, let me look here. Hold on. This book, for anybody who has mystery pain and you just don't know what's causing your pain, Facing Pelvic Pain, it's fabulous. It's just a great book, and it's free on Kindle Unlimited. Let's just see what she says in here. I mean, what these doctors say. I'm one of the authors of this book too, but I wrote the support chapter. I didn't write the gynecology chapter, obviously. Eliza, can you describe the pain? Is it sharp, dull, burning, electrical? Do you feel like you're being shocked? Describe. Can you describe the pain a little bit more? And does it only happen when you put the estrogen in, or does it happen at any other time? Deanna says, you're incredible, Jill. Thank you for all you do for those of us trying to live each day with IC. Oh, Deanna, thank you so much. That's so sweet. I really, listen, I was saying to my dad this morning that as we all contemplate our life stories and why things happen, I would not be here today if my parents had not helped me. Flat out tell you that. And I was saying to my dad this morning, I said, do you realize that because you saved my life, we get to now help thousands and thousands of other people? And he hadn't really thought about it like that. Okay. Eliza said, only when you put it on, it burns first, and then it feels like a heavy pain, a trauma-like pain. And have you ever had that pain at any other time? Is this a completely distinct pain, only related to the estrogen cream? Wait, and then when you wipe off the cream, it stops in 10 minutes? What kind? Are you using Premarin? Is it Premarin? Is it estrase, or is it a compounded estrogen cream? That's really interesting. I'm just curious. Oh, speaking of pictures, somebody asked earlier. And Eliza, is it in a cream base? Is it in a oil base like coconut oil? What's the base of it? Somebody was asking earlier about why does a full bowel make your IC worse? Well, look at this picture. Now you can see how close things are. Right? So if you've got a full bowel, especially if you've got kind of an enlarged rectal area, sometimes you can get something that they call packing, where you just end up with a lot of poop sitting right inside your rectum, and it's stretching everything out. And as it stretches it out, it starts to push on other things. I have had that many times myself. Okay, you're doing estradiol cream. I'm seeing a second doc in New Jersey because my doc in Pennsylvania is treating me with instillation. That is unusual. Is it made by a compounding pharmacy? I mean, it almost sounds like you're having a skin sensitivity issue that's referring to a nerve deeper in. Marlia says, so V-Magic will not work the same as estradiol cream. No, not. V-Magic is only a temporary fix. Estradiol is more permanent fix. Is that right? Yes, because estradiol changes the skin and V-Magic can't do that. Absolutely. Marlia, absolutely. V-Magic For patients who cannot use estrogen because they are also cancer patients, although that's a whole nother discussion, there are some patients out there who just cannot or will not or won't use estrogen. And so without the estrogen, that mucosal layer is going to continue to get thinner and thinner and thinner. And so their only defense is to use something like coconut oil or V-Magic that you can put over these wounds to try to give your skin a little bit of extra protection. And V-Magic is, where is it? Oh, here it is. So this is Medicine Mama's V-Magic. This is, in my opinion, one of the better products that we sell on the IC Network website. Many, many patients use this. It most closely mimics natural mucus. It's made with extra virgin olive oil, extra virgin avocado oil, beeswax, honey, sea buckthorn, and propolis. And what's great about it, see, like you can see it on my fingers here, is it's a nice coating, but it's not sticky at all. You know how Vaseline is very sticky? This is not sticky. And because it's an oil base, it'll stay on the skin. So if, for example, you were swimming, there's women who swim, especially if you're of a certain age, that chlorine can burn the vulva. But putting this on before you swim onto your vulva can actually keep that chlorine away from your skin and make it less irritating. So this is really good stuff. Really, really good stuff. Eliza said, no, it's a 0.01% prescription. That's exactly what I had. She did a cystoscopy and a pudendal nerve repair and Botox injections and took a biopsy and found many mast cells. Okay. So because she found a lot of mast cells, did she put you on an antihistamine? Like hydroxyzine, Vistaril? The way you're describing it is really, I mean, I totally believe you. Believe me, I totally believe you. But it is really interesting and really unusual. So in Curtis Nichols' he proposed 9 phenotypes for IC. One of his phenotypes is a new one that nobody else has talked about yet, and that is an allergenic phenotype. And so for patients with a history of allergies, or the way he determined this, okay, so this is interesting, and you can go to our website and you can print out the article. The way that he determined if somebody had an allergenic driven cystitis is when you have a cystoscopy. So here's your bladder, right? So here's your bladder on the side, and they're putting a cystoscope through your urethra, right? So now we've got a cystoscope, and they're looking at the bladder, right? So they're looking at the bladder wall. What he did is he pushed the cystoscope up and gently palpated, gently touched the bladder wall. And then he pulled it back. And if in that area it turned red and got puffy, he defined that as an allergenic bladder. Nobody else has ever talked about that. He was the one who talked about that. And I think it's brilliant. It's called developing a wheal, W-H-E-A-L. So if you touch the bladder, a little bit of pressure, but not sharp pressure, pull it back. And if it turns red and develops a wheal, that's when he suggested patients be prescribed an antihistamine. And I think that's absolutely brilliant. Eliza said, you can't stand that pain from the estradiol. I wish I could go and be a part of that study, but I can't. Oh, that's a good point. So we did announce a new clinical trial Friday or Thursday. this is a phase 1 clinical trial, which means the purpose of this 6-week study is to make sure that they are using the correct dosages. So it's a safety and dosing study for a new therapy, I'm not allowed to talk about it, but I can tell you it's a logical therapy, a variation of something that is currently in use. So, it's extremely viable, right? So anyway, they have developed their protocol. They believe that they have found something that can be helpful for the bladder wall. They are willing to pay patients $20,000 to participate. It's in Ohio, but it means that you're going to have to be at their clinical trial facility. Think spa. They're going to serve icy-friendly food to you, and they're going to do a lot of blood draws, because they just want to watch what the medication does, if anything, in the bloodstream. So over 6 weeks, it's going to be like 10 blood draws a week. And if you are interested in participating in this study, you can go to our website or go to our Facebook page or go to my Twitter page. We just announced it, and you can give them a phone call and learn a little bit more about it. I have turned down several studies that I do not believe are credible. One of the studies that I turned down was a repurposed thalidomide study. If you don't know what thalidomide is an old medication that was given back in the 60s for women who were suffering from pregnancy-driven side effects. So they thought that they had found a medication that was safe to use during pregnancy, and it turned out it wasn't. And thalidomide ended up causing severe birth defects and was pulled from the market. But it's still around. Now, if you ever see a study that says no children of childbearing age, as this study that somebody brought to me years ago, I was like, why? And they go, oh, well, it's thalidomide. And I went, what? You want to test thalidomide in the IC patient population? The great majority of women are in their childbearing ages. And I turned it down. It's like, no, not interested. But ultimately, in the end, it carries risk, and you need to learn a lot more about it. I can't tell you that it's going to be safe because they don't have the safety data. It's logical. It's potentially promising, but you have to learn a lot about it from the researchers to decide if you would like to do that or not. Eliza says, right now, tramadol and Lyrica help me. Okay. So, hey, man. Eliza, just know that with the Lyrica in particular, when you're ready to stop the Lyrica, you can't just cold turkey it. There's something called Lyrica discontinuation syndrome. There are several drugs that cause what we call a discontinuation syndrome. And basically what that means, normally when you're on meds like that, you gradually reduce the dose, right? So if you take 100 milligrams, you would then do 90 for a week, and then 80 for a week, and 70 for a week, although there are no medications that are actually that easily organized. The problem with some medications is, let's just say they only go down to 100 milligrams. There's nothing below that. So your lowest dose is 100 milligrams. And if it's a pill you can't cut in half, then you've got to go from 100 to 0. And that can be a shock to the system, and that can cause withdrawal symptoms. It's not an opiate that's where we think about withdrawal. It's just a discontinuation syndrome. So it's a bit of a beast to get through. Okay, I mean, just fair warning. I believe everybody you need to be fully informed. Lyrica discontinuation syndrome I'm trying to remember some of the others. Hold on. So when you're ready, you just have to be very thoughtful about it. So Lyrica discontinuation syndrome symptoms are, hold on. It can cause anxiety, confusion, difficulty sleeping when use is discontinued. Hold on. So insomnia, anxiety after an abrupt discontinuation. In addition, so this is a study that was done in Japan 2 years ago. And let me just read you this little abstract, because I think it'll help you just kind of understand. So Lyrica pregabalin is a drug that can cause psychiatric symptoms with pregabalin withdrawal. Prior reports pregabalin withdrawal have mainly focused on cases with dependence or abuse, and little attention has been paid to patients who are prescribed regular doses. Herein, we report 3 cases of pregabalin withdrawal in patients without psychiatric disorders who were taking regular doses and who developed symptoms such as insomnia and anxiety after the abrupt discontinuation. They believe that withdrawal, this can occur even with regular doses or even short-term use, and clinicians must carefully reduce doses when reducing or discontinuing treatment and paying close attention to symptoms. All right. Oh, so interesting cases. So 39-year-old man who had a back injury, an upper right neuropathic pain, no, and he'd taken it 600 milligrams per day. He had loss of appetite, insomnia, and anxiety. Yeah. Palpitations, restlessness, anxiety. Yeah. Wouldn't it be nice if they actually told you this? Yeah, it does. It crosses the blood-brain barrier. Absolutely. Missy says vulva specialist, a gynecologist would be the person you'd work with for vulvar issues. But again, remember, doctors play in their sandbox. The gynecologist can assume that it's a problem with the vulva when in fact it can be a problem with muscles immediately above the vulva. So you got to be a little open-minded here. Do your reading on vulvodynia before you go, okay? Let's see here. Let me see. Oops, that's not the right file. There we go. So, let me see. So I think what I would like to do is, oops. So I have been reading chapters out of our book, IC 101. It's not just a bladder disease. So let's go ahead and do the next chapter, which is on related conditions. If you have any questions that you would like to ask me on IC, please don't hesitate. Please go ahead and ask. I'm here. You got me. And it's hard to get me during the week, let me tell you. Eliza said, it's strange. I took dicyclomine for an IBS flare and it helped lessen the Hunner's pain. Let's look at that real quick. Oh, Bentyl. It's an antispasmodic for often used in irritable bowel syndrome. Okay. So it's a smooth muscle antispasmodic. And so in addition to helping calm bowel spasms, it potentially could help calm bladder spasms. So that makes a little bit more sense. Okay. From if you don't have it yet, IC 101, it's not just a bladder disease. Our baby, I'm going to be rewriting portions of this summer to have all the new updated guidelines in it. Okay, anyway. This is chapter 4, related conditions. Millions of Americans suffer with chronic pain disorders. Oh, you know what? Hold on. I got to take my flipper out. Hold on. I want you to see this. Okay. If I'm going to talk, I lost 2 teeth to a bad dental hygienist, and I'm waiting for my implants, which I won't have until the summer. But it's hard to talk. So real teeth now. Okay. Millions of Americans suffer with chronic pain disorders, including vulvodynia, TMJ, myalgic encephalitis, known as chronic fatigue, irritable bowel, IC, fibromyalgia, endometriosis, chronic tension headache, chronic migraine, and low back pain. When someone has 2 or more of these conditions, they are diagnosed with chronic overlapping pain conditions. The Chronic Pain Research Alliance, chronicpainresearch.org, has worked for more than a decade to help us understand why these conditions often occur together, and their studies continue to implicate an altered, more sensitive nervous system. Small fiber polyneuropathy. Small fiber polyneuropathy has been found in over 60% of patients who struggle with chronic overlapping pain conditions. Small fibers are the nerves that have the smallest diameter and are found in abundance in our skin, where they relay information about pain and temperature to your central nervous system. When they are malfunctioning, patients experience heightened pain sensations. Small fibers also are found in the bladder, bowel, and in blood vessels, where they too become more sensitive. Patients may feel full when small amounts of urine are present in the bladder, which we often call a false sense of fullness. Neuropathies occur when a nerve isn't functioning normally. In some cases, a disease such as diabetes, Lyme disease, herpes simplex, or chickenpox may have damaged the nerves. A vitamin B12 deficiency or an excess of vitamin B6 can contribute to nerve dysfunction. Some chemicals and heavy metals are quite toxic and damaging to the nervous system, including chemotherapeutics, platinum, taxanes, bortezomib, and vinca alkaloids. Even some antibiotics have been linked to neuropathies, including nitrofurantoin, fluoroquinolones, and TMP-SMX. Symptoms can occur both in the skin and organs, including cold-like pain, burning, tingling, pins and needles, electrical pain, allodynia, and hypersensitivity. Hello, sensitive skin. In the autonomic nervous system, it can trigger dysautonomia, dry eyes, dry mouth, dry skin, dizziness, lightheadedness when standing, GI dysmotility, gastroparesis, neurogenic bladder, erectile dysfunction, and abnormal sweating. After the diagnosis is confirmed via a small skin biopsy, treatment is focused on calming the nervous system. It is vitally important to stop ongoing damage to allow nerve fibers to regenerate. And if a B12 deficiency is found, it should be treated immediately. Neuropathic pain can be treated in 6 potential ways: antidepressant medications, anti-epileptic medications, opioid medications, topical medications such as lidocaine or capsaicin, neuromodulation and transcranial magnetic stimulation, and some patients may require the use of immunomodulatory agents such as IVIG. Okay, so that's one, small fiber polyneuropathy. Our next related condition is called sympathetic nervous system fight or flight dysfunction. In some IC and most COPC patients, brain studies have also demonstrated that certain portions of the brain have changed size while communication between parts of the brain is diminished. Most importantly, the amygdala, the portion of the brain that directly controls the fight or flight response, appears to be constantly on, leaving the nervous system in a constant state of distress and exhaustion. Unfortunately, this then intensifies pain perception as well as anxiety, depression, and catastrophizing, helplessness, and pessimism. Let's see. At no point is anyone suggesting that chronic overlapping pain conditions is a mental illness. Rather, they see it as a nervous system under duress. Physical trauma, such as repetitive falls or impacts, are common. With each progressive injury, muscles are injured, are weakened, and nerves wound up. Tailbone injuries, which have the potential of traumatizing nerves at the sacrum and spinal cord, are also common in the IC and pelvic pain patient community. Generally, the longer the pain occurs, the more the potential there is for nerves to become sensitive. Some patients, however, did not suffer a physical injury. They often have a history of abuse. Imagine a child who is beaten or abused randomly by a family member. Every time they enter a room, their brain enters fight or flight. If it happens constantly, the brain gets habituated and stays in fight or flight. The same is true for children and adults who are bullied. If you enter an environment that is emotionally or socially abusive, you will enter fight or flight, and that will change over time how your brain functions. But there is hope. Just as the brain and nerves can be damaged through trauma, they can also be improved, and this is where mind-body medicine succeeds greatly. Chronic overlapping pain patients must embark upon a program designed to calm their nervous system and restore good brain function. This is known as the neuroplastic response. A key goal of therapy is to help the nerves and brain adapt and manage pain better. This can be done in remarkably simple ways. Regular exercise, healthy eating, quitting smoking can create a foundation for good brain and nervous system health. Keeping the mind active, engaged, and challenged is important. Yes, that means using your mind by reading, doing puzzles, learning new languages. Daily relaxation, keeping stress low is critical to winding down a more reactive nervous system. In contrast, the excessive consumption of caffeine can be overstimulating. It is the concept of mindfulness that is the most promising. Mindfulness meditation helps to change the brain through neuroplasticity. The more calm and peace we teach our brain, the more we react to life stressors with that same sense of calm. Harvard Medical School has done multiple studies that show that mind-body medicine that teaches patients meditation, yoga, cognitive skills, and positivity result in less pain, fewer medical services, and lower healthcare expenses. Music can also help. It not only improves your mood, It can also make beneficial structural and functional changes to the brain. Trained musicians have noticeably different development of key brain areas, such as the corpus callosum, cortex, cerebellum, and gray matter. Turn on music that gives you peace, joy, and makes you dance. Chronic overlapping pain conditions should not assume that their condition is incurable. In fact, the brain and the nervous system are remarkably resilient. Patients who have had strokes can relearn how to perform basic tasks because their brain is capable of adapting. This is neuroplasticity at its best. Research into mind-body medicine and mindfulness shows remarkable success, which is why they are the cornerstone of most chronic pain management programs. And in the book, When It Hurts Down There, 15 Proven Techniques to Alleviate Pelvic Pain, Dr. Angie Storr explains that when pain is accompanied by high levels of anxiety, the brain will intensify that pain, likely out of concern that your life may be in jeopardy. Thus, it's important that patients consider all factors that are adding stress and anxiety to their daily lives. If anxiety is dominating your daily life, it's time to take an anxiety management class to improve your skills. Luckily, pain that is accompanied by laughter is minimized by the brain. One of your daily priorities should be to laugh more, seek joy, and do things every day that make you happy. Learn more about the remarkable successes of neuroplasticity at positivepsychology.com. Our next related condition is pelvic floor dysfunction. And Sandy, if you don't mind holding that question, actually, before I go there, let me answer Sandy's question, okay? Sandy says, I was seen in the ER on February 28th for severe pain and prolapse. Thinking it was just my IC flaring up. They found oh, honey, they found a cantaloupe-sized tumor on my right ovary. The wonderful woman who did my CT scan said, my poor bladder is smashed flat. I'm so scared to have this surgery. Oh, honey, don't be afraid to have the surgery. Wow, this is encouraging. They found it. They found it. So whether it's a tumor, whether it's a fibroid, which is a benign tumor, an ovarian cyst. Listen, ovaries. I mean, I've had, how many ovarian cysts have I had? At least a dozen over time. I threw ovarian cysts like a beast when I was in college. It was amazing. And they were so incredibly painful. And if we think about this picture, which I showed earlier, let me see. Okay. So let's look at this picture here for a moment. So here we have the rectum. Here we have the vagina and the uterus. And you can see the little ovary right there. And here's the bladder right there. But your ovary is not a little ovary. It's cantaloupe. It's huge. And it's basically probably laying right on top of your bladder because of gravity. When you walk around, that heaviness is going to push right down on top of your bladder. So this is this is great that they found this. We know from the fibroid tumor research, because the fibroid tumor research, I think if I remember correctly, showed that 75% of patients with fibroids reported bladder symptoms. Is that right? Or was it 75% of patients who had their fibroids removed said that their bladder symptoms went away? Okay, I don't remember which study. All I remember was the 75%. Okay. But we know from that work, removing fibroid tumors that were pushing on the bladder, the patients responded beautifully. So there's really, I can't imagine your doctor saying to keep it, because it's in all likelihood going to continue to grow and continue to get bigger. So, I mean, I would assume that that's what your gynecologist would recommend, that you remove it, right? So the surgery makes total sense. Makes total sense to have that removed. The question is, how are they going to do it? With a tumor that big, I would imagine that it would have to be a bikini incision as compared to doing a vaginal one, because there's no way that your vagina, well, I mean, you can pass a baby through your vagina, but I think hormones play a role in that too, in terms of releasing everything. I would just want to know technique. How do they propose to do it? Bikini incision. I mean, millions and millions of women have bikini incisions. So a bikini incision goes basically from, it's probably this long, hip bone to hip bone, but it's probably like 5 or 6 inches long. It's amazing. And I did this when I was doing surgery in college. I was amazed that I could make a little tiny incision. I mean, I could make a little tiny incision and just with forceps stretch it, never break the skin. I just stretch it, and I could make this little tiny incision be this big. So, okay. Then you're just bringing up my next one. So if they can't do the horizontal incision, they would do a vertical incision, a vertical C-section incision. Okay. So that's going to be in a line below your belly button. When are they going to do this, Sandy? What's your surgery date? I mean, I think that there's a very good chance that your bladder symptoms might go away completely. April 17th. Okay. I'm going to put you on my calendar. Monday, huh? I want to try to make sure that I send you something. I don't know if we're friends on Facebook. We should be friends on Facebook, Sandy. Are we? I can't switch over to my personal account. You had 4 days before your birthday. You know what? I started my experimental IC treatment on my birthday years ago, and I was so glad I did it. I thought, you know what? If there's ever a time I want to do it, it's on my birthday, because this is about my future. This is about my future. I'm Jill Heidi Osborne on Facebook. So everybody, I want you to send Sandy good vibes. Sandy, listen, girl. Now I say this because this is, listen. When I started the IC Network, I was extremely academic and very, very poised and postured. Not anymore. It's been 30 years. And I talk very, very differently now. And so I'm going to say this in the best possible way. You are a tough bitch. And I want you to have that attitude. You're tough. You're strong. You have lived with this for probably years. You have been through hell from this, sis. And so this is exciting that they found it, that they can remove it, and that you are going to get through this recovery. But it's important. It's, as Renee here says, getting a second opinion would be reasonable. I would want a really experienced surgeon doing this. So for the surgeon who's proposing to do it, I mean, are they younger or are they older? Have they operated on these types of tumors or cysts before? Have they seen complications? Have they seen successes? Right? You have the right to ask a lot of questions. You're not passive. Remember, you pay them. They don't pay you. You get to ask a lot of questions. Um, 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 and you know where I would go for support um, is Hister Sisters. Hister Sisters is I know you're not having a hysterectomy, but Hister Sisters is a fantastic support community for women who are considering hysterectomy, going through one, or are recovering from one. And they there's a lot of resources on the recovery from surgery, including from vertical incisions as compared to horizontal incisions. And so the vertical incision is definitely, as they told you, the more challenging incision. You're going to listen, they are going to give you very, very strict guidance on what you can and cannot do after surgery. This is very true for hysterectomy and especially vertical incision. So you're going to have to understand that you're not going to be able to lift anything for like 6 months. I mean, like, and when you go grocery shopping, you're going to have to keep your bags really, really light, or you're going to have somebody else lift your bags, because this is about protecting the incision and giving those tissues time to heal and strengthen again. But oh, so you already had the hysterectomy. Okay, there you go. Yeah, Renee says, do not lift. No, yeah, I ruptured stitches at 6 weeks picking up a t-shirt. Okay, hold on. I hear yelling. Hold on. What's going on here? Oh, he was taking a shower, Mom. He had to put on his clothes. Okay. You can sit on your pot here. Do you need to? No, I'm going right out there. I'm going right out there. Okay, come this way, Dad. She probably couldn't hear you in the shower. Mom, you can sit right here. I'm out of here. I know, but okay. Okay. Maybe she has the same problem, you know. Oh, your eye's looking good. It's healing quite nicely. All right. Okay. Okay, we're going to park this here. Okay, I've got your hand. You're going to put that hand here. Okay, I've got you. Okay, put your hand there. Pick up your left foot. You have to pick up your foot, step on top of the foot. Are you going to pee or poo? Okay. All right, go ahead and sit down. Did you have an accident? Go. All is well. All is well. Sandy says, I plan on parking my butt in my recliner lift chair for weeks. My husband gets to do all the heavy lifting. Exactly. Guys, that was my deaf mother trying to get into her bathroom because she's had an accident, not understanding that my father was just getting out of the shower and she was trying to push in and he was trying to push out and she's leaking. Such is the life of elder care. All right, getting back to Sandy. So Sandy's going to have, so Sandy, the good news here is that you already know you got through the hysterectomy. So if you can get through hysterectomy, you can get through the surgery. You know, you're tough in the best possible way, right? Renee says, Sandy, I live in Georgia and I did four prolapses fixed and a hysterectomy. I had no choice. Scar tissue fibroids, one the size of an orange. Endo, I had no idea I had all of this. I thought I might have a vaginal prolapse starting, but not the other things. Ask questions and do not get in a hurry on recovery. You will get through this. Rest and do not go. You know, I got to tell you, one of the things that absolutely shocked me was a patient who called who had, so she had urethral cancer from HPV. So this was a girl like in her early 30s. You know, that's why the human papillomavirus vaccine is so important. There are many different human papillomaviruses. There are 8 variations that cause cancer. And she sadly got exposed in her 20s to this very virulent cancer-causing virus. So she was diagnosed with urethral cancer. And it was aggressive. And so she was completely cleaned out. They took her urethra, they took her bladder, they took her vagina. I think they kept her bowel. They weren't sure, right? And nobody told her what the recovery time would be. Somebody told her she would be back to work in 6 weeks after having a hysterectomy and her bladder removed, having a stoma. And she said she tried to go to work. She couldn't. It was too painful. I'm like, honey, who the hell told you you could go back to work in 6 weeks after having this massive surgery? Damn. I mean, that's like 6 months. Poor thing. I felt so sorry for her. We have to be, and I think that, it's windy outside. Doctors have a tendency to sugarcoat things because they know if you worry about it, that you might worry too much and make things worse. But we got to be real on expectations and post-operative recovery. So girl, we send you all our love. You got this, and you got this. You just got this. Yes. She said, oh my goodness, that is, it was completely insane. I mean, I had muscle spasms for 10 months after my hysterectomy. If somebody tried to tell me to work 6 weeks after my hysterectomy, are you bloody kidding me? No way. I can barely sit down. Becky says, it was very hard not getting candy coated. I pray you get better fast. I got in a hurry. Do not get in a hurry. You know, Sandy, what I did after mine, I got to tell you, I was really honest because I'm number one, I did a lot of my mind body medicine stop sign. Every time I worried about it, I visualized the stop sign, did a nice slow deep breath, and said it's going to go well. You know, I mean, I was very assertive and aggressive with my thoughts as I was driving to the hospital, so I wouldn't worry about it, and it worked really, really well. Um, but in the end, I resorted to blackmail. If you do it, Jill, you can have a cinnamon roll every day for 2 weeks, which is which I did. I did. Reward therapy, you know? I mean, I believe in reward therapy. Whenever my parents have a doctor's appointment, we always stop and get donuts at Dunkin' Donuts, you know? Hold on a sec. I just got an email from somebody. Hold on. What was that all about? Oh, ironically. Ooh, yikes. I don't want to use your name if you're in here, but did you just send me an email about Strep B? If you did, it could certainly trigger UTI. And yes, it will probably require antibiotics. If you had high amounts of Strep B, yeah. Okay. Did I miss anything? All right, you guys on YouTube, you're being very quiet. All right, let me go back to, so I've been reading chapter 4, related conditions. Let me read the section on pelvic floor. And this will answer a question somebody just asked. Okay, pelvic floor dysfunction. Pelvic floor muscles are a muscular hammock-like structure that support the internal pelvic organs and help in the movement of our hips and legs. Visualize a three-sided box open to the front. Here you go. Three-sided box open to the front, right? That's your pelvis. These skeletal muscles are found at the base of the pelvic cavity as well as up the sides. There are also 3 layers of muscles from shallow to deep, and any of these muscles can be injured or become dysfunctional. Unfortunately, because they lie deep within the pelvis and cannot be observed with the naked eye, it can be difficult to locate the injury without an internal examination via the vagina in women or the rectum in men. Tight muscles can be triggered by pain. If you have a bladder infection, an icy flare from drinking coffee, if you hold your urine too long, bladder pain will quickly trigger pelvic floor muscle tension. This is called the viscerosomatic or guarding reflex. For these patients, the therapeutic priority is to ease the source of the pain with the hope that the pelvic floor muscles will eventually relax. However, many IC patients report that their urinary symptoms began directly after a pelvic injury, such as a fall, difficult childbirth, sexual abuse, or extreme sports. This is known as the somatovisceral reflex, where the muscle dysfunction triggers changes in the bladder and other organs. Tight pelvic floor muscles can cause bladder pain, vulvodynia, rectal pain, testicular pain, and so forth. When you fall on your hip or your buttock, you sustain a compression injury to the tissue. The muscle fibers are basically squished and damaged by the fall. Blood vessels in that area can be broken, which explains why bruising occurs. And very tiny blood vessels and nerve fibers can also be damaged, leading to nerve dysfunction. Nerves must have a good blood supply to function normally. The muscles which took the brunt of the fall are now weakened, and because they still have a job to do, such as holding your SI joint together, they will overcompensate and become tight. The muscles can become very hard and rigid rather than soft and pliant. Blood vessels and nerves which pass through those muscles are then compressed. Sciatica, for example, occurs when tight piriformis muscles squeeze the sciatic nerve. Chronically tight pelvic floor muscles can occur because of skeletal abnormalities, including scoliosis, a bad hip, and SI dysfunction, knee or foot abnormalities. If you have one leg longer than the other or don't walk normally due to overpronation, Morton's toe, Morton's neuroma, plantar fasciitis, or shin splints, this dysfunction is directed up your legs and into pelvic muscles. Repetitive pelvic trauma is commonly seen in pelvic pain patients, especially in gymnasts, ice skaters, bicycle riders, football players, triathletes, and paratroopers. Ballet dancers are taught to tuck their pelvic floor under when they walk, which can then create dysfunction and pain years later. Bicycle seats, motorcycles, and saddles can push deeply into the pelvic cavity where they injure muscles and nerves. And in some cases, children tighten their muscles in response to sexual abuse or to prevent bedwetting, resulting in a decades-long dysfunction. Some women have struggled with vaginismus for years and have been unable to enjoy intimacy or pelvic examinations without pain. Pelvic floor injury patients often have no clue that their muscles are the problem. Therefore, symptoms can be urinary frequency, urgency, pressure, or pain. They and their doctors often assume it's a urinary tract infection, but antibiotic therapy doesn't work. They may be told that they have overactive bladder, prostatitis, or interstitial cystitis, often using those therapies for years without success. Bladder medications might ease some symptoms, but they don't resolve the fundamental problem for the patient. The therapeutic priority for the pelvic floor dysfunction patient is to restore muscle tone and enhance blood flow in the pelvis. With better blood supply, the organs begin to calm and heal. Tight muscles are known for causing burning and or pain because muscles that are working hard build up lactic acid in the tissue. It's common for pelvic floor dysfunction patients to feel burning in the vagina or testicles. A pulling, pushing, or dropping sensation may be felt. The most consistent symptom of PFD is difficulty starting the urine stream. Patients may sit or stand for several seconds or minutes before they can relax their muscles and release urine. Hi, Sue. Multiple research studies have found pelvic floor physical therapy to be successful in easing pelvic pain and icy symptoms. In fact, it performs better than most bladder therapies. Patients are usually referred to a pelvic floor physical therapist by their urologist or gynecologist. At the first appointment, the therapist should look for tension patterns in the legs, back, pelvis, and abdomen. They will do a brief internal examination to gently palpate muscle groups. Let us show you. This is what they do. They touch muscles. If they touch a muscle and trigger pain, this is a success. It means they found it. The patient should immediately ask what structure or muscle they are touching. Some find internal pelvic examinations awkward or embarrassing. Please remember that the only way that they can assess the health of these muscles is by touching them. They are gentle and professional. They will tell you exactly what they are doing while they are doing it. And you, in return, should be telling them what you feel. It's a two-way process and conversation. For some patients who have been the victim of sexual abuse or rape, having a pelvic examination may be too difficult and or could trigger PTSD. These patients should share their history with the physical therapist, along with any concerns or worries that they have. The physical therapist can start externally and just work on the soft tissues in the leg and back over several weeks. And as those muscles relax, the pelvic floor should also begin to relax. But more importantly, this will build trust with the therapist and may slowly progress towards some inner work. but the patient is always the boss. They can't have internal work on any given day. The physical therapist must respect that. Understand, though, that hands-on muscle work is the best way to restore muscle function. We strongly urge patients to familiarize themselves with various pelvic floor muscles before they visit the therapist so that they can share which muscles they think are causing the problem. This will help them visualize which muscles are being treated. Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss is a master class in pelvic anatomy and will help patients understand how and why muscles, hold on. I just lost my thought. Okay. We'll understand how and why muscles can cause or contribute to bladder and pelvic pain symptoms. Because dysfunctional muscles are often present for months or years, pelvic floor physical therapy will take time. Patients should not expect a quick fix or after a few visits. They may need to see a physical therapist for several months as they work together to relax muscles and restore function. In some cases, patients may be referred to an orthopedic surgeon or a podiatrist to address other issues that could be triggering their tight muscles. Physical therapists will also provide exercises that can be done at home to help relax and then strengthen the muscles. But here's a consumer alert. Kegel exercises should be avoided by patients who struggle with muscle tension. They are designed to tighten weak muscles that are associated with incontinence, and if you do them, they will only increase your already out of control muscle tension. If physical therapy is not covered by insurance, we recommend trying to see a physical therapist at least once for a proper assessment so that they can identify the muscles that are involved. They should also provide some exercises that can be done at home. YouTube has many videos produced by physical therapists that will help patients understand how to rehabilitate specific muscle groups such as the levator ani, piriformis, or psoas. And then perhaps the patients can go back to the physical therapist months later to see if they're making a progress. Okay, now you guys, I want you to understand, you're never going to figure it out on your own. Do not try to dive into pelvic floor work without first having somebody identify which muscle group is the problem. Because for all we know, you may latch on to the term levator ani and go to YouTube and watch a video on how to improve the levator ani. But maybe your problem isn't the levator ani. Maybe your problem is the piriformis, and maybe the exercises you're doing for the levator ani might make the piriformis worse. So you really can't start this on your own. It's very important that you have somebody identify which muscle group is the problem first. Okay, so if you can only go to physical therapy once, go for that pelvic floor assessment so that they can give you an idea of the landscape and they can give you the names of the muscles that are the problem. Now, you also have to understand that, and I'm the perfect example of this, listen, physical therapy was incredibly successful for me. But you can hurt yourself again. And your pelvic floor muscles can be injured again, which means you may have to go through pelvic floor physical therapy again. Muscles can be hurt easily. Now, trigger points. The bane of many pelvic pain patients are trigger points, hard knots of muscles that over time perpetuate blood flow restriction and nerve dysfunction. Trigger points can be found in any muscles. There are two types of trigger points, active and latent. Active trigger points may be sensitive to touch and may trigger referred pain. Active trigger points can hurt when the muscle is used or when the muscle is at rest. Latent trigger points only hurt when they are pressed, but they can still contribute to muscle shortening, weakness, and restricted movement. Latent trigger points can also become active when the involved muscles are overstretched or overused. Trigger points should be addressed quickly to prevent widespread pain, including the use of direct and indirect myofascial release, strain and counterstrain release, strumming, muscle and energy techniques, joint mobilizations, organ-specific fascial mobility, integrative manual therapy, strengthening, indirect and direct stretching, neuromuscular reeducation, as well as at-home exercise. Let's see. Dry needling may also help. Our next related condition, here, hold on. I'm going to take a question from Arlene here. I've been accepted into a study that uses Botox in an area of the bladder that is not usually injected. I have not used Botox for my bladder. I'm very wary. What do you think? Well, Botox comes with risks. The biggest risk of Botox therapy is that they can accidentally turn off or silence the nerve that helps you urinate. So the biggest risk of Botox therapy is urinary retention. And, when they do Botox therapy, they're, basically injecting different parts of your bladder wall, but they can't see where the nerves are. And so if they accidentally silence that nerve, which plays a big role in your ability to empty your bladder, you may have to self-catheterize for a couple weeks or a couple of months until the Botox wears off. The good news is Botox always does, always, I think it's always, I might be wrong about that. Botox usually wears off and your ability to urinate returns. Arlene, I would have a lot of questions for that, for the doctors in the research study about what adverse events have they seen. And if they mention urinary retention, how is it treated? How long did it require treatment? And will they pay for the equipment? Will they pay you for the catheters that are going to be required for you to self-catheterize for as long as you need them? With any luck, it'll only be a couple of weeks. But if urinary retention is longer than that, then they should be paying for everything in this research study, okay? Okay, our next related condition is pudendal neuralgia. And let me see. You know what? I think, you know what? I'll do pudendal neuralgia, and that'll be the last one. Good. She sent you information to read. Good. Our last related condition, then we'll stop here. Pudendal neuralgia is an inflammation of the pudendal nerve. The pudendal nerve emerges from the sacrum, and I showed you a picture of this, but let me show you another picture of this. This is important. Okay. Here you go. This is exactly what we're talking about. So if we get our model here, here's your sacrum. See those 4 holes? The spinal cord comes down here and it sends the pudendal nerve through those 4 holes into your pelvis. Okay. As these nerves come out of the sacrum, they are basically going through your pelvic floor muscles. Do you see this right here? So it starts out as 3 or 4 nerve groups, and then you're going to see that they solidify into one group, or they merge into just one clear nerve group to go under this, which is called the Alcock's canal. And then they leave the Alcock's canal, and this is when they differentiate again, and it goes up and down your crotch to innervate your urethra and your rectum and all that sort of stuff, right? Okay, but you can see these nerves right here, and you can see how enmeshed they are with muscles. This is my problem. So annoying. All right, so hold on. So the pudendal nerve emerges from the sacrum and crosses the piriformis muscle, also known as your hip rotator. It then travels through the Alcock's canal that splits into several branches that provide nerve function and sensation throughout the crotch. The perineal branch of the pudendal nerve supplies the muscles of the pelvic floor, the labia, and the scrotal skin, the clitoris, and penile and erectile dysfunctions. The symptoms of pudendal neuralgia include pelvic pain, urgency frequency, difficulty with urination and defecation, painful intercourse. In women, pain may affect the urethra, vulva, perineum, and buttocks. Men may experience pain in the penis, urethra, perineum, scrotum, and buttocks, and it can be felt with ejaculation. Because the perineal area is the most common area of pain, patients are advised to elevate this area while sitting to prevent pressure. Pain with sitting that gets better standing, a classic symptom. Pudendal neuralgia can result after childbirth, vaginal surgery, chronic vaginal infections, or injury to the tailbone, and or compression from a bike seat. Pelvic floor dysfunction and sacroiliac problems can also be responsible for an inflamed pudendal nerve. Because sitting triggers pain, patients are more comfortable standing, lying down, or sitting on a toilet seat. A variety of meds can be used in nerve blocks to treat PN, such as an injection of an anesthetic, a steroid, a benzodiazepine, an opioid, heparin, or epinephrine. Because pudendal neuralgia can coexist with IC, epinephrine may not be a good choice for patients because it is known for triggering frequency urgency. When a nerve block works only temporarily, the patient can be tested to see if the nerve is entrapped. Surgery or nerve stimulation may be necessary, but is not always reliable. Pudendal nerve entrapment is a rare condition because many doctors have not treated before. We urge you to seek out a professional with solid experience in PNE therapy. The sooner it is treated, the less chance that the nerve will suffer more damage. And that's what I have on my left side. And that's what causes this vibration when I sit for long periods of time. And now I have a vibration that goes down to my heels, both legs. And I have a new appointment with my sports injury guy because it's a sports injury. So anyway. All right, guys. Well, listen, I think we've come to our natural end. We've been here for 3 hours. I will hopefully see you all again, knock on wood, next Sunday. In any case, I wish you a spectacular week. Find calm in your daily life. Walk away from stressful situations. You and I have the responsibility to make sure that we are creating an environment that will support healing in our body, and that means physically, mentally, and emotionally. We know that pain will be exacerbated if you're really anxious and upset. So you got to work on your stress management a little bit. Get out, walk, get out in nature, talk to people who make you feel good, walk away from people who make you feel bad. Carry hope in your heart. Do your affirmations. I can do all things through my faith, which strengthens me. Every day in every way, my life will get better and better and better. Be bold, and mighty forces shall come to thy aid. Next Sunday is Easter. Oh, thank you, Gay. Oh, so I will probably not be doing a meeting next Sunday then. I have no idea what the family's going to do because we had COVID, and we had COVID 2 weeks ago, and all of my extended family close by, everybody had COVID. So are they going to be COVID free enough to come to our house and see my parents? Probably not. So anyway, guys, I wish you the best. Wish you absolutely the best. Be well and know that you're not alone. You're absolutely not alone. And if you ever feel a moment, you just feel that you need a little pep talk, you're always welcome to give me a phone call. I'm always happy to do that. But sometimes, when I was taking an anxiety management class, they talked about how do you handle situations that will make you really anxious, like a job interview or dealing with somebody who has been abusive. How do you prep for that? And hi, Diane, and the class was stellar. And what they said is, think about somebody that's a role model for you, or think about somebody that you admire, right? And ask yourself, how would they handle that situation? So if you walked into a doctor's office and you had somebody who was going to demean you, think about your role model. How would your role model handle that situation? How would Dolly Parton handle a doctor telling her it was all in her head? Think about that for a moment. Do you think she would accept that? Oh, hell no, she would not accept that. She would say, good sir, I thank you for your time. I deserve to be treated by a doctor who will treat me with respect. Good day. And walk out with her head held high, right? That's how Dolly Parton would handle that. So sometimes as you're facing the daily stresses of your life, think about how somebody that you admire would handle that, and then embody them. And I think Dolly Parton's a great role model. I think she's a fantastic role model. There's a great new documentary on her on Netflix that I watched like a week ago. But you know, I'm not saying I'm worth being a role model, but if you ever feel like you just need a little extra oomph, pretend you're me. You know, how would Jill handle this situation? What Jill would say is, good sir, I have read the American with Urology Association guidelines for interstitial cystitis. I can tell you that the treatment that you are suggesting is not even discussed in the guidelines. And so based upon that alone, I am not interested in doing your experimental therapy. I would like to follow the national guidelines, right? Dolly is an amazing lady. But, you know, if you want to pretend that you're me, be bold. A mighty forces shall come to thy aid. You know, it is what it is. Arlene said, I did ask about retention. I will ask more questions. She sent the information to read. Okay. I mean, the advantage of participating in the study is that you're going to get free care for the study, but there are risks. Diane said, I'm having a bladder distension with ulcer-like areas cauterized on Tuesday. I'm hoping it will lessen pain and frequency. Diane, that's what the research shows. The research shows that when ulcers are treated, the pain goes away in like 90% of the patients who have them treated, probably higher than that. You just have to understand that, I mean, there are two different ways I would go with that. Concept number one is that it's an aggressive procedure. And so you got to double down on your diet for a couple of weeks. I mean, double down on your diet for an extended period of time. You know, and hopefully you have a little bit of pain care for the week after you have that done. Just to deal with the post-operative pain. I have gotten to the point now in my life that if I'm going to have a procedure that I know could be painful, and I'm sorry, allergies are really bad right now. I tell them at my pre-op, I want pain meds. I don't need a lot of pain meds. I'm not asking for 6 months. I'm not even asking for a month, but I would like some pain meds to cover the post-op. A week. I think we can all agree that I'm not going to become a drug addict if you give me 9 pills of Norco, but I want some pain meds on board. Diane's, and if they refuse, it would make it very difficult for me to be their patient. When I went through my cancer, all that drama, every single time I said, listen, I'm not doing this without pain meds, period, end of story. Because the trend now, even for things like major surgeries, is to actually not give a patient an opiate. My mother did a hip replacement on Tylenol and Advil. And I'm going to tell you right now, she suffered like a beast. And so I am very blunt, and I just say, listen, I'm not doing this without some pain care. And they're like, oh, we'll give it to you at the hospital. I'm like, no, I want it now. I don't trust them at the hospital. I want to have a prescription filled at my home so that when I get home, I will have pain care, period, end of story. I don't want to wait in the car for an hour. I want it now. And again, I'm not asking for a lot. Just give me a week's worth. Give me, that's, and nobody ever turned me down. And I barely used them, but I'm sure glad that well, after my hysterectomy, believe me, I used them pretty significantly that first week. But after that, things improved fairly rapidly with respect to pain. Diane says regular Tylenol and ibuprofen doesn't help enough. That's all I take now. Well, you just don't know, hun. You just don't know. Arlene says, so difficult to get pain meds. Decades ago, I got Tylenol after a C-section. Yeah. I think it's very important that you be the squeaky wheel. Now, listen, it's really just going to be the first 24 hours that could be the most uncomfortable, because they obviously they have to do a hydrodistension to stretch your bladder, and then they're going to cauterize your bladder, and that's the equivalent of branding a cow. They're using heat to close a wound. And so the skin, it's not going to be happy right away. Your skin will be going, ow, 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 what did you just do to me? But it should go away fairly quickly. I would hope that you would be feeling better within 3 or 4 days. But if, one of the common adverse events of anytime you have a hydrodistension with cystoscopy is they can introduce infection. Anytime you push an instrument up through the urethra into the bladder, you run the risk of potentially introducing bacteria. So we call that a nosocomial infection, an infection acquired in a healthcare setting. So if you start to feel, if you feel fairly good and like at day 3 or day 4, all of a sudden you're bad again, then that really means that it brings up the issue that perhaps you could have picked up a post-op infection. So if that happens, if your symptoms suddenly get worse rather than better, definitely call your doctor. Let them know. They're probably going to need to check your urine and treat that. Okay, so we would expect that you would just gradually improve over that first week. But if you level out and then go down again, be very squeaky about that. Make sure you tell the doctor about that. And Diane says, I'm hoping they give me an antibiotic before the procedure like they did. Yeah, they should. They should. They might give you an injection. They might give you some antibiotics to take at home too, depending upon what they find. Arlene says, I needed fentanyl after my last hydrodistension. They gave me 2 doses in the recovery room. Yeah. Well, the most traumatic thing you can do to a hollow organ is stretch it, right? Think about how bad your stomach hurts if you eat too much. Well, when you distend the bladder with water, you are stretching it. And that's why it should be done in the operating room as an outpatient procedure. In the old days, doctors did that in their office. And they said, oh, you'll be just fine, while the patient's literally screaming. Stretching the bladder is traumatic. And so it should always be done in the OR. I think that's what our guidelines say, as an outpatient procedure with proper anesthetic. Arlene said it was San Francisco Kaiser. Are you kidding me? Was that a regular... was that one of the pelvic pain specialists, or was it a regular OBGYN? And I sure hope you filed a complaint. That's one good thing about Kaiser is they're very good about asking for feedback. And if I'm ever mistreated I got a radiologist fired from Kaiser. I did. I went in for avoiding cystogram, and I had avoiding cystogram is where they fill your bladder with fluid. And then they look at it with basically an X-ray, because they want to see where the urine is going. Is any urine going up your ureters, or is it going down into your bladder, into your urethra, right, as you're voiding? And so it was one of the screening tests I had to have to get into a research study I was in. And she refused to read the letter from my urologist. And the letter from my urologist said, do not overfill her bladder. Her bladder capacity is 500 cc's. Do not go over that. Now, I'm not an idiot, right? I'm not an idiot. So I'm laying there and I see the IV pole with a bag of 1,000 cc's of fluid. And I look at that and I look at her and I look at that and go, you're not going to use all that, are you? And her answer was, don't tell me how to do my test. And I said, I have a letter from my urologist saying you should not do that. You will hurt me. And her attitude was, do not tell me how to do my test. Shut up. That was her attitude. She didn't say shut up, but that's what she did. And by that time, she's already putting fluid in my bladder, and I'm laying there, and I had a hydrodistension with no anesthesia. She put all 1,000 in my bladder. Arlene says, I was screaming in pain. I was sobbing. I was sobbing in pain. That bitch. And then so I've got this. She goes, well, just pee around the catheter. How? How the hell do you pee around an instrument? I couldn't do it. And she finally stopped and emptied my bladder, and I walked out a sobbing lunatic. 2 days later, I got an evaluation form. How was your visit at Kaiser? I let him have it. And the chief of the department called me and personally apologized and said, I'm so sorry. This should never have happened to you. And she was fired. No regrets. No regrets. She refused to consult with another doctor. So anyway, so Diane says, I'll be put completely under for general anesthesia. Good. And that, honey, and that was what we call a high pressure long duration. You're not going to have a high pressure, just so you know. So the situations are not equitable at all. They say you should be able to work 2 days later. You might be able to. Some people walk out of that and they can go out to dinner 2 hours after having it done. It all depends upon the finesse of the doctor. I hope you're one of those people. I hope that life just goes on. There's a good chance it will. Because remember, my experience was 30 years ago. It was exactly 30 years ago, maybe even this month, when they didn't know any of this. Okay, now they know all this. So what happened to me is not going to happen to you. Okay, so you're self-employed, honey. I would want to be home. I would want to be home for about 4 days. I would cancel appointments that require you to travel. I would. If you can reschedule them for another week. But if you're working with them on the phone, you should be fine working with them on the phone, or even video conference, Zooms, you should be fine. But if it requires you getting in a car and going somewhere, I would be very tempted to push that off for a couple of days. Just to be real, you get to come first. And it's hard for those of us that are self-employed, because obviously I'm self-employed too. Arlene said she thought the doctor was cautious, and her Florida Uro said she didn't stretch it enough. Well, yeah. Look at the new guidelines. The guidelines don't recommend that anymore. It's all low pressure, short duration. Oh, good. You'll be home doing telehealth? Well, I think you'll be fine for being home. And the cool thing is you only have to, if you're on video, you only have to worry about what shows, above your waist. So I think you'll be fine. And yeah, I really like the idea of getting the antibiotic, and they will probably give that to you anyway. They might just give you a shot and not even tell you about it. But I think it's worth bringing it up and saying, are you going to do anything like that just out of curiosity? Right? All right, guys, let's call it. Be well. Have a good one. Sending you my love. We are in this together. We are in this together. Always remember that you've got millions of men and women standing side by side with you as you walk into these appointments. Okay? All right. Sweatpants. Hey, man, yoga pants. I'm wearing my yoga pants. My yoga pants and my beloved Hokas. You gotta love Hokas. These shoes are the bomb. They're so good. All right, guys, I'll see you later.